Dr. Vijaya. Before we begin the session, I would very briefly like to introduce our chairperson. Professor Shubure is working as a professor at Department of Anthropology, University of Calcutta, West Bengal. He has also served as the head of this department. I welcome you, sir, wholeheartedly. And our co-chairperson, Dr. B.S. Aribam, is working as an assistant professor at Department of Anthropology, Dr. Harsing Gaur Vishwavidyalaya, Sagar, Madhya Pradesh. I will welcome you, Dr. Vijaya.
Yes, ma'am, I'm here.
So nice to see you, Vijaya.
Yeah, very nice to see you and hear you.
I request you, sir, Professor Shubore, to please start the session.
Well, thank you so much, Dr. Shivani Chandal. A good morning, ladies and gentlemen. A very good morning to all of you. I welcome you in this second day of the opening session of the second day, and we have three very distinguished scholars in this session: Dr. Urfat Anjim Mir, uh, Dr. Chakravarti Mahajan, and Dr. Mitashri Srivastav. And the title of the session, as Dr. Chandel has explained before you, is Psychological Health and Well-being. I welcome all the speakers into this session, and without wasting time, I invite Dr. Urfat Mir to make his presentation.
Morning, everyone. Thank you very much, Professor Subare. And I would also like to thank the organizers for giving us this opportunity to become part of this seminar, which is being held in the honor of Professor PC Joshi. And personally, for me, it's like a long association with Professor Joshi, and indeed, I have been introduced by him, to this area of research that I will be actually discussing today. Going back to the days when he was head of the department in Institute of Human Behavior and Applied Sciences, the association started from, my orientation to the field of trauma studies and medical anthropology actually begins from 1999. I also consider it as an honor to actually, discuss something that he has sort of, helped me learn, and he has sort of, helped me in many ways, not only actually, conceptualize, theoretically understand, but also practically carry out research work in field in this area. And on many occasions, as part of the projects which I did with him, under him, and otherwise as well, he has been very kind enough to actually travel to the field. So a lot of this, actually, the credit of all of this actually goes to him for whatever I am here, and whatever I'll be presenting today. I would like to request the host to allow me to share the screen because I'll be using PPT. Yeah, okay. Thank you. Is it visible?
Yeah, Urfat, it is.
Yeah, absolutely visible.
Okay,
absolutely visible.
Okay, thank you very much. So the title of my presentation is, adolescent mental health in conflict settings, anthropological insights. The outline of my presentation is I will be actually critically examining the various findings, research findings in the area of adolescent mental health with respect to conflict settings. Now, by doing this, what I'm essentially trying to highlight is the need, for an anthropological approach which exclusively focuses on social and cultural aspects of the trauma suffering and mental health among adolescents. Before doing so, I would just like to briefly give you a background of this. For example, when we look at children and adolescents, the children and adolescent population, across the world, what one realizes is that 35 to 50% of the population in low and middle income countries. Now, when I say this especially because what we also realize is that that most of these conflict situations are also actually in not essentially in Western world. So that's one aspect. The other is that, with respect to the mental health disorders as well, when it comes to the onset of mental health disorders, again, adolescence is the age. That's the time when maybe most of these mental health disorders also actually begin. So again, when it comes to worldwide prevalence rates for child and adolescent mental disorders, the figures vary from 10 to 20%. That is what the UNDP study also shows. But at the same time, what we realize is that the World Health Organization also considers violent social conflicts, collective violence as a major public health problem. Now, why it is considered so? Simply because it affects the combatants, the defense forces, the civilians, and of course, within the civilians, the adolescents and children as well. Now, what one realizes again, as per the United Nations figures, that 230 million children actually live in these 33 major conflict-affected countries. And as a result of that, around 13.5 million children have been internally displaced as a result of wars. And we know that that these wars destroy the homes and the communities that are supposed to provide physical and social protection, to these children and adolescents. Then Brenna and Falisard in 2018 also mentioned that the mental health problems of youth are actually likely to be one of the main public health challenges of the 21st century. Now, coming back to this point, when one looks at violence, conflict, and health, what one realizes is that that majority of world's violent political conflicts in the past 50 years have taken place in non-westernized societies. Yet, to understand the impacts of conflicts, to understand the mental health impacts, and otherwise as well, largely what happens is that that the cosmology is quite distinct from these found in industrialized nations are actually used for this sake. And largely these impacts have been actually understood, these health costs have been understood only through clinical diagnostic based approach of biomedicine. Now, who are the ones who actually, when it comes to the people who actually get affected in conflicts, who are the ones? Of course, there are these civilian combatants, there are paramilitaries, there are guerrillas, there are child soldiers. But what is interesting to note here is that when it comes to the, the casualties of the conflict situations, again, beyond in 2010 and based on other studies that have already been done, found that only 10% of the people who actually become casualty of these conflict situations are the soldiers. The 90% of the casualties are actually from the civilians. Now, within those civilians, the adolescents as well. So that's how it becomes very alarming that ultimately the conflict situations take a heavy toll when it comes to civilian populations. When we look at conflict settings and mental health of adolescents, there are a number of studies in journal which actually talk about that how exposure to political violence has adverse impact on the social and psychological functioning of children and adolescents. Now, it leads to, of course, majorly post-traumatic stress disorder, anxiety symptoms, depressive symptoms, and somatic disorders. These are studies that have been carried out world over. Now, if we look at it specifically, because PTSD is actually a disorder that have been sort of trying to focus exclusively on in the context of the conflict in Jammu and Kashmir state, in Indian context. Now, if we look at it globally as well, for example, what happens when it comes to emergence of PTSD or prevalence of PTSD rates in conflict zones, the prevalence rates actually range from 8.6% to 10%. But essentially, when it comes to other events in Indian situation, like exposure to accidents, death of a close one, coming close to being killed, and so on and so forth, we find that kind of a traumatic event also leading to post-traumatic stress disorder, and the 10% is the prevalence rate for that. But otherwise, when we look at it globally, it's like 50 to 70% of children exposed to political violence in the in warlike situations in the Middle East end up developing these symptoms. That is what Dimitri actually found in 2011. Of course, the prevalence of mental disorders in general and PTSD in specific is higher among children, who experience recurrent violence, for whom violence becomes, everyday experience. Violence becomes, in certain sense, a daily, experience. With respect to, for example, some of the studies, that have been carried out exclusively in the state of Jammu and Kashmir, Mushtaq Margoof, again, being a psychiatrist, reports that, 40.62% of the sample, was found to have this, followed by major, depressive disorder. Then, again, what one finds here is that, it is like, this medicalization of trauma situation in a sense, which is constructed majorly by psychiatrists and psychologists. Very least contributions by medical anthropologists or anthropologists in actually understanding this medicalization, or the phenomena of the medicalization, or the aspects of this medicalization. So similarly, John et al., also another psychiatrist in the state of Jammu and Kashmir, carried out a study in 2017, report that the attempts to suicide and other psychiatric illnesses also similarly are there. Now, in this background, why is it that we need anthropological approach? For what we do need anthropological approach? The anthropological approach derives its significance from the fact that since we lack this investigation, thorough investigation of the subjective meanings and significance of the experience of trauma and mental illness, for the individuals who actually undergo this on everyday basis, on daily basis, where this recurrent trauma actually becomes a routine in a sort of a new normal. Fine. Now, does it have the same kind of effect or a varying effect when it comes to actually trauma experience, which is maybe once in a lifetime kind of experience? One. The other is that does it have the same kind of experience or impact, the kind of impact that it actually creates in maybe Western world, in individualized societies? So where are the cultural variations? Where are the cultural differences? So that's where I think it becomes important. And in this context, Arthur Filman also argues that understanding of pathology is insufficient without incorporating the social and cultural aspects. So the social and cultural aspects become very important. Why these impacts are important is simply because social and cultural aspects of an individual's life are significant indicators, to illustrate the difference between social suffering that a person experiences because of the prevailing social conditions in which they live, and development of pathology, because there are these perspectives of social suffering and structural violence also. Social suffering again led by Arthur Finman, and structural violence, which was initially given by Galtung, but then Paul Farmer, who actually uses it especially in the context of clinical practice. That how the social becomes very important in clinical practices, also in construction of clinical diagnostic entities as well, and it has a role. Now, again, some of the studies that some of the critique of this clinical diagnostic construction is also from within the psychiatric community as well. The ones who actually lead that are Derek Summerfield and Drake also, who mentions that that psychological distress is never experienced in a vacuum. It is invariably the result of social and the community experience. Fine. So the social and community experience, what one finds in these psychiatric studies and findings is that there's no mention of that, especially when it comes to subjective meanings of trauma, for which cultural idioms of distress also become very important. So the language in which is manifested and expressed by the sufferers, by the adolescents of the general population as well. There was this one study which was actually carried out on methodological aspects of evaluating the methodological aspects of studying trauma. What was found in those was that mostly these standardized scales, which are based on diagnostic and statistical manual of American Psychiatric Association, or maybe International Classification of Diseases framework of the World Health Organization, are the scales that are actually drawing essentially from these symptoms that have been conceptualized in the Western world by psychiatrists and clinical psychologists. So the cultural, social, contextual meanings and expressions find very little or maybe no mention in those scales, in those standard measurement scales. So that's where I think the perspective of social suffering becomes very important. And in the perspective of social suffering, Arthur Kleinman, as I earlier also mentioned, Arthur Kleinman, Paul Farmer, and on many other scholars at international level have actually been at the forefront of trying to highlight the importance of anthropological approach. And here again, Professor PC Joshi in our Indian context has been actually at the forefront of trying to look at the subjective meanings of trauma suffering and the manifestation of the trauma symptomology, the social implications of that, social aspects of that. So coming back to this social suffering, this social suffering perspective actually views trauma survivors outside the standard victim-patient role, where the construction is actually of individual pathological condition. It actually goes beyond that, and it sort of, is also in a way what Arthur Kleinman says, PTSD meticalizes problems that for maybe much of human history in the West have been appreciated as religious or social problems. That's also one of the things that when it comes to health-seeking behavior or health, beliefs regarding trauma suffering, that how one understands it, how one perceives it. There are cultural variations in that as well. Whether the same, if one strictly goes by diagnostic statistical manual, APA diagnostic statistical manual or 30th diagnostic criteria, then even hearing about a traumatic experience of a friend or a family, member can become traumatic for an individual. And, because when it comes to the symptoms of post-traumatic stress disorder, there are probably three categories. One is re-experiencing, that event, flashbacks of that event, numbness, loss of appetite, or maybe dysfunctionality. So re-experiencing or flashbacks of those events can be there, even though this term actually, if one goes by this critical analysis of Alan Young as a medical anthropologist, and this is a term, that has been constructed especially for the sake of giving medical benefits and other privileges and benefits to war veterans, especially, in the case of Vietnam War veterans. Fine, but then how that has been actually, extended to universally medicalize the suffering of populations in conflict zones or, man-made or other natural traumatic events as well. So again, Arthur Kleinman actually provides us a framework, a very precise framework for understanding trauma and PTSD through anthropological approach. And he argues that medicalization of political violence violates the expression of that trauma because it removes the human context. Because in medicalization within the biomedical model, within the psychiatric model, it is individual pathological condition, which sort of does not give that much of an importance or significance or credence to the human context, to the social cultural context of the individual. So that's where Arthur Kleinman also actually talks about it. There are other terms also that are used, for it, which are cultural bereavement, memories, disengra, similarly, and structural violence approach also that help us actually understand this. Now, this the concept of social suffering is essentially used to refer to the lived experience of pain, damage, injury, deprivation, and loss through the social.
Dr. Urfat, 5 more minutes.
Okay, thank you. Yeah, sure, I'll do. So these subjective components of distress are, as have been illustrated to be rooted in social situations and conditions, that have cultural circumstances. Now, when we, compare this psychiatric model, with the social suffering framework, what comes out is that, that maybe imposing a rigid diagnostic model of psychiatric healing in conflict zones has been perceived as appropriating the suffering of people at multiple levels. Now, whether psychiatric diagnosis and treatment are used as an institutional or a state means to silence the violence or device of resistance by turning structural violence into stigma and misfortune of individuals and reduce the traumatic reactions to pathological conditions. It's also again something which is very interesting. Either Hosseini in the context of Palestine, conflict also reports that for example, how there is medicalization of trauma also. Because this medicalization of trauma also, sort of at times fits into the or maybe fulfills the purposes of the the various actors in a conflict situation. So whether it is the state that actually uses that to pathologize individual suffering, or whether it is the non-state actors are the ones who actually are in the resistance mode, who actually use that broadly as a framework to highlight the costs of the trauma, the costs of the perpetration of occupation and so on and so forth. So in some ways, on one hand, the prevalence of psychiatric illnesses, mental disorders, leads to pathologizing the same condition as individual problem. At the same time, also helps in highlighting the costs of that conflict, and which serves the purposes of various narratives. So that's where one also has to actually look at it in that context as well. When it comes to this local context versus the universal context, because the biomedical model and the psychiatric model is actually trying to universalize this experience and understand it through a universal approach, which becomes problematic and which is also incomplete, which is not a comprehensive understanding if one were to actually look at the social cultural variation that actually exists in the way that humans act and behave and respond to traumatic situations. So that's where there's a need for mental health professionals to be more accepting to the local, regional, and alternative process of cultural healing. Such collaborations between professionals from the biomedical sector, alternative medicine sector, traditional religious healers have been proven to be successful. Even in the context of, for example, the Kashmir, where I have been carrying out, research studies on impacts of mental health, impacts of violence on the mental health of adolescents. The religious healing, the folk healing, and the community healing. In terms of the kind of the resilience that is actually there. Another important thing which one actually finds here is that also that most of these studies actually talk about medicalization of of trauma, and there are very less studies actually about the resilience, the coping of individuals, of communities, in those who actually live in these recurrent conflict situations. Now, in conclusion, what one can say is that the discipline of clinical psychology and psychiatry, owing to their dominant Western medical illness perspective, tend to practice an individualistic orientation in diagnosis and treatment of mental illness, which is very tough social cultural aspects. So that's where anthropological approach becomes very important, because these diagnostic treatment models do not take into account the aspects of suffering of collective societies, of the role of the community, of the role of the social in it. There's also a need for actually doing an interdisciplinary review of the effectiveness of interventions, that are actually launched in these conflict situations, especially, what interventions work best, under what conditions, and interventions for whom, what are the resources that are needed, and why those are there. Again, there was this one study which was actually carried out in the context of the, the Afghanistan, even though, the role of the allied forces and the psychologists and, sociologists also came under scrutiny at that point of time, because they were the ones who were actually, part of those human terrain teams that were constituted by the allied forces to break the psychological resistance of the local communities. And anthropologists, given their, history of, given their history of their role in colonial administration, maybe were the ones who actually stayed away from it. So it was interesting to note that, in this war against terrorism, anthropologists were not at the forefront of actually helping the allied forces, but then the psychologists and the sociologists were the one. But then after some time, even their associations actually passed the resolutions for ethical reasons. They were the ones who actually did not. So what I'm saying is, in that context also, that what kind of interventions, whether those interventions are for the sake of helping the state, helping the community members. So there is that kind of a literature, that kind of possibility also that we need to actually carry out. The other aspect which I highlighted earlier as well is that there's a need to actually go beyond medicalization of trauma and understand the resilience, as opposed to risk and vulnerability, to understand how individuals, how adolescents also negotiate with this recurrent trauma, and that's where anthropologists have a very important role to play. And the last point is that I think it's high time that we actually anthropologists try to look at this clinical Western dominated diagnostic model and look at the social aspects, the meanings, subjective meanings, and the narratives of the trauma in our context. And it becomes important for us also because it's not only in Kashmir. We have this Naxalite issue as well. Then the violence in Punjab, of course, was there. It's no more there, but still it's there. Then we have this impacts. This incidence of communal violence and the whole of northeastern region. That's been there having this problem of insurgency. More so a reason for us to actually look at the aspects of the resilience. I explore firstly the meanings of trauma, the manifestation of trauma, and then explore how adolescents actually negotiate and cope with these incidents of trauma in our context. Thank you very much. With this, I would like to end my presentation.
Well, thank you, Dr. Urfat. I would like to request the moderator of this session to say a few words, and then we can move on to our next speaker, Dr. Chakravarti Mahajan. Well, we should. I think the moderator is not audible, but I must congratulate Dr. Urfat. Yeah, Dr. Mir. Yeah.
Professor Sumare, there's one question in the comments. There's one question in the comments. If you permit, I would like to respond.
Yeah. Please.
Oh, thank you very much. There's a question that one query: what kind of methodology will help us in understanding the subjective experiences at an individual level, knowing that it may lead to revisit of the trauma by the sufferer, by the sufferer concerned. It's a very important question. It's also a ethical question that when it comes to actually understanding trauma, it essentially involves making that individual feel that trauma again, revisit that, and which is highly painful for that person to actually recall and reflect those events. Yet at the same time, it becomes very critical also in the case of adolescents, if one were to actually carry out study on them. But at the same time, I think the in-depth methodological approach of the anthropologists, which is primarily the essence of the fieldwork approach, provides those possibilities of interacting with adolescents or any population participants over a period of time, and of course use a life history narrative approach, of that qualitative interaction approach, of eliciting the responses, of understanding the trauma experiences. So the pure qualitative approach actually is more appropriate in helping us understand rather than actually using the standardized scales of the psychiatrists or the psychologists that are used. So that's why even though I also initially used actually the mixed methods approach, because for me what was important was also to know the extent of the symptoms of the trauma experiences. Fine, so that's where I used PTSD primary care screen, which can be used by non-clinicians as well. So that way, what is important here is also that and as anthropologists who are well versed with qualitative inquiry, who are well versed with eliciting thick descriptions, I think that's where that extended fieldwork gives us that opportunity of carrying out research work. Thank you.
Well, thank you. We will take up any other questions at the end of the session. Professor Mitra, we will take your question at the end of the session. Just one comment. It's very interesting, Dr. Urfat. Adolescents, because of their age, they have their own stress of growing up to become the future adult. At the same time, in a conflict-ridden situation, this is an additional stress to them. So they are actually reeled with this dual burden of stress and how they cope. And it will be interesting also to see that in conflict-ridden situation, situation, how the childhood stress act, and also of the adult. But especially adolescence is very important because they reel under double burden of stress. Thank you so much, Dr. Urfat. Thank you. And now I invite our next speaker, Dr. Chakravarti Mahajan. He will be speaking on a topic: psychological health and well-being, and among infertile women, a hospital-based case control study. I invite Dr. Chakravarti Mahajan.
Thank you very much, sir. Very good morning to all of you. And Surya's question um, it has, gave me. In fact, I'm actually thinking how my journey from a qualitative ethnographic research to this particular study has taken the whole trajectory. I was actually wondering while I read that question and when I saw Dr. Mir responding to it. And I think that is where Professor Joshi's role is very important. He's someone who's inspired me to do collaborative work in the department. And he's always advocated for mixed method approaches. And that's how he, along with Professor Saraswati, they involved me in their previous project, which was on suicide in Andhra Pradesh. And then from there, organically, we thought of this particular study, this paper, which I'll be presenting today, is part of a larger study, which is funded by National Commission for Women. And the larger study has two main objectives. One, of course, is to see the impact of infertility on psychological health as well as well-being on women. And the second one is to design a counseling document, a counseling guide for medical professionals to deal with women who are under stress due to this particular condition. So, Dr. Avitoli, can you share my presentation? The title of my presentation, as you can see on your screens, is Psychological Health and Well-being Among Infertile Women. It's a hospital-based case control study from India. Next, please. Infertility is defined as the state of failure to conceive after 1 year of unprotected sexual intercourse. Infertility affects millions of individuals and couples, and the estimates vary from 48.5 million couples to 120 million women worldwide. The prevalence of infertility ranges from 8% to 12% worldwide, with very high infertility prevalence in South Asia, Sub-Saharan Africa, and the Middle East. When it comes to Indian situation, we have seen that in India, although we don't have, our estimates are rough, but total number of infertile couples in India in 2010, Ganguly and Unisa, they are at the Institute of Population Studies. They estimated that around 14 million couples in India, they are infertile. The Indian Society for Assisted Reproduction has stated that in India, up to 1 in 6 couples have difficulties in conceiving, and also a majority of them, they seek medical advice and treatment. We all know that infertility has social consequences. Humans bear an inherent desire to reproduce. Procreation is seen as a critical behavior in human society, and it is strongly related to the ultimate goals of completeness, happiness, and family integration. Failure to procreate can have social and psychological consequences on individual, and these may range from overt ostracism or divorce to more subtle forms of social stigma, leading to isolation and mental distress. Thus, infertility serves as a poorly controlled chronic stressor with severe and long-lasting negative social and psychological consequences on couples. Studies reveal that infertility-driven stress has direct and indirect effect on infertile couples that decreases their evaluations of life as a whole, self-sufficiency. It affects work-life balance. It also affects intimacy and overall health of the couples. Both infertile women and men tend to have more psychiatric morbidity all over the world. In highly pro-natalist and patriarchal societies like India, women suffer the burnt of childlessness, and it has social, psychological, and physical consequences. Infertility leads to abuse, marital instability, and social isolation, along with loss of self-esteem. This has been reported in many of the studies which Indian scholars have carried out. So the present paper is actually a part of a larger collaborative study. The study is still going on. We initiated the study in 2019, and we'll wrap it up in sometime later this year in December 2021. As I've told you, this study is funded by National Commission for Women, and we have a collab. We have two collaborating institute. One is within Delhi University, the Department of Psychology, from where Professor Nandita Babu is our collaborator. From Lady Hardinge Medical College, Professor Manju Puri, who's the director of Gynecology Department, she's our collaborator. From our department, Professor Saraswati and myself, we are investigators in the project. The larger aim, next slide, please. The aim of this study is to understand the impact of infertility on the psychological health and well-being of women. So we are trying to answer a few questions such as what are the factors that determine psychological health and well-being in infertile women? How is their life how their life is affected by the experience of infertility and its treatment? Can there be a social intervention tool that can help clinicians to provide better treatment and care for infertile women? And what I'm doing today is sharing some of the basic results from the study. So when it comes to methods, the present study is being carried out at the Department of Gynecology at Lady Hardinge Medical College. The total sample size of the study is 500 women, out of which 250 women are infertile, and we have taken age-matched fertile women. When it comes to infertility data on infertile women, we collected all the data in the hospital setting, in the OPD of Lady Hardinge Medical College's gynecology department, whereas age-matched sample was collected from the areas, so we actually did, we went to community and we went to the women who were living in close vicinity of the infertile women, just to see. I mean, initially we were trying for area match also, but then age match was the primary criteria. The data for this study was collected from August 2020 to February 2021, and this was also the period when COVID-19's first wave was going on. Our research team, they did a lot of hard work. They went and collected data from OPD, and the OPD of Lady Hardinge Medical College, it has a dedicated day, which is Tuesday, for infertility clinic. So there is no separate infertility ward as such, but every Tuesday there's this clinic which is run for the women who are infertile. Next, please. For interviewing women, pre-tested quantitative interview schedule was used. The schedule included demographic variables, household composition, educational status of the women, occupational status, socioeconomic status, and family structure, along with lifestyle, nutrition, and reproductive profile. Today, I'll be focusing on the second part of the schedule, which consists of psychological tools for stress, anxiety, depression, as well as tools for psychological well-being and emotional well-being. So these are the tools which we have used for both cases and controls. For stress, we used perceived stress scale. For anxiety, we used GAD-7. For depression, we used PHQ-9. For psychological well-being, we used WHO-5. And for emotional well-being, we used PANAS. Next, results. So next, please. That's actually the data on all the 5 scales. If you see the first, next, please, because there's this table. So according to perceived stress scale scores, 87% of infertile women experience stress, of which 64% of women experience moderate stress and 22% of the women experience severe stress. Among the fertile women, 64% of the women were found stressed, of which 60% experienced moderate stress, and only 4% of the women experienced severe stress. Stress was higher in infertile women with a significant association. According to regression analysis of various variables with stress, the husband's occupational status was one of the causes of the stress among infertile women. The men who were daily wage earners or who did not earn at all were more stressed to infertile women than men in better jobs like government sector and business. Next, please. According to GAD-7, 44% of infertile women had anxiety, including 27% had moderate anxiety and 16% had severe anxiety. Among the fertile women, the 23% women were found to be anxious, of which 21% were had moderate anxiety, whereas only 2% had severe anxiety. Next, please. Depression was one of the most common psychiatric disorders found among the infertile patients. One of the participant also described that she sleeps entire day and for her, days are very, very lethargic. She also doesn't. She's someone who doesn't want to take treatment, but it was because of her husband and family pressure that she was coming to the OPD. So when it comes to PHQ-9 responses, 77% of infertile women had depression, of which 39% women had mild depression, whereas 26% women had moderate depression and 15% women had moderately severe depression. 3% of the women had severe depression. Women with severe depression cases, they were we consulted our collaborator at the institute, Professor Manjupuri, and through her intervention, they were sent to the psychiatry department for further consultation. Next, please. When it comes to psychological well-being among infertile women, we found that 50%, 55% of the respondents had a score indicating flawed psychological well-being. There was a prevalence of signs of depression among 17% of infertile women who had scores below 7. Among fertile women, 15% of the women indicated poor psychological well-being and 85% indicated average or good psychological well-being. There was a significant difference in psychological well-being scores of infertile women and fertile women. These issues were generally related to the duration of infertility. And the longer the participants experienced infertility, the more they had poor psychological well-being. Infertile women with more than 5 years of
Dr.
infertility.
Chakravarti, 5 more minutes.
Yes, sir. Thank you, sir. The infertile women for more than 5 years of experience of infertility had poor psychological well-being. Next, please. When it comes to emotional well-being, the PANAS SF positive scores in the study, we found that 82% of the infertile women and 22% of the fertile women had scores less than the mean positive score of the positive emotional aspects of the PANAS scale, and 18% of the infertile women and 77% of the fertile women had scores more than the mean positive score. We found that the positive emotional well-being among the infertile women was affected by the duration of infertility, physical activity, and belief system. Women who were infertile for less than 5 years had better well-being scores than those who were infertile for more than five years. Some general observations which I want to share before I conclude. When it comes to infertile women, we found them they were more prone to mental health and psychological disorders and had poor well-being than fertile women. The infertile women often use the expression being tensed to express their constant worrying towards childbearing. Infertile women could better understand and respond to the questions asked from the psychological tools as compared to fertile women. The infertile women had experienced a higher degree of psychological duress from their husbands, family members, and community in general. They had a constant desire to have a child, and this desire intensified every month because most of these women were visiting the OPT every month, bringing them misery and personal discomfort. This misery and discomfort, coupled with failure to achieve a viable pregnancy, further affected the sexual life of the infertile couples, which in turn intensified their feeling of hopelessness and reduced self-worth. Infertile couples who had invested a lot of money, resources. Some of these women were daily wager and they would come from far off places. Sometimes, we met women who had would travel from Hapod, from Sonipat, from other parts of NCR, and often they had to let go of their daily wage to come and visit. Since some of who know Lady Hardinge Medical College, it caters to poor sections of the society and also the lower middle class. So the socioeconomic composition of the group, although I've not shown that data here, but 50% of our sample came from Dalit communities, from scheduled castes. So when it comes to infertility, although it's a very, very, to say that we found women who were infertile, they were psychologically distressed and had poor psychological health and well-being as compared to fertile women. That's a finding which is there in many studies, and our study actually corresponds to those studies. But in this particular work, we also found that hospital settings, women who were treated with infertility, their psychological health and well-being was not taken into account because the focus of the doctors was on the physical health part, on treating infertility. The study records that women struggling with infertility require psychological and emotional support in terms of counseling. And as I've already told you, one of the primary objectives, the second objective of the study, is to prepare a counseling guide for medical professionals who deal with women struggling with infertility. In future, we are also thinking of carrying out more detailed qualitative studies with the same group of women, although that project will come after this one, in which we would like to understand from women about their body image issues, about the kind of conjugal stress they go through, also the decision-making activities which happen at the level of household. And when is it that these women, they opt for medical intervention? Also the role of media in propagating for a certain kind of treatment, because now a lot of private clinics are mushrooming, and there's another work which one of my PhD students is doing in Lucknow. She's working on infertility clinics, especially IVF clinics in Lucknow, and she's found that even in those clinics, although the doctors, they deal with middle class and upper and elite of the society, but a lot of poor women frequent those clinics as well. So this is just a beginning. We are thinking of carrying out more work on this area. Thank you very much. Thanks. Thank you all for your patience.
Thank you. Thank you, Dr. Chakravarti, for this thought-provoking lecture. And actually, I sometimes wonder why humans desire to reproduce. Is it an inherent desire, or is it a pressure from inside or outside? Or is it a social obligation to reproduce? Or do we want to replicate ourselves? So we have also done some little bit of work, and as you rightly said, qualitative data will help you a lot. And secondly, the class and caste factors, occupational pattern, all these play a very important role in what to say, understand, in absorbing, how they deal with infertility. Is it they deal it casually or very seriously or whatever? So this is very important, and I would like to just quick suggestion that go for a multivariate statistics with this quantitative data to remove the confounders and to see whether fertility or infertility factors, they really make differences in stress level. Rest of the questions will be picked up by our moderator after the end of the session. Thank you so much, Dr. Chakravarti. And now we invite Dr. Mitashri Srivastava. She will be speaking on the topic disability and adoption, anthropological reflections on mental health and well-being of children with special needs in India. With this, I invite Mitashri.
Thank you so much, sir. And thank you so much for giving a lead inspiration by stating that the desire to reproduce has to be questioned, because I personally feel that it cripples a certain section of the society, especially the children, the disabled children I'm going to talk about. So it's like a divine alignment between what Dr. Mahajan is speaking and what I'm going to speak today. The theme of my presentation is disability and adoption, anthropological reflections on mental health and the well-being of children with special needs in India. And I'm an old school scholar, so I'm not going to present any PPT here, but I'll keep the presentation in a dialogue mode. And I'll begin with some candid confessions. The content of the paper was actually conceptualized a few years back when I had just ventured into exploring certain bit of anthropology of disability studies. And I remember in one of the seminars, I had presented a few findings of this paper, and our very own chairperson, sir, Professor Ray, sir, who also happens to be my first teacher in anthropology, he gave me a lot of initial motivation that this area has a lot of scope and perhaps I should explore it more. And since then, I had been in search of a good student, a sensitive student, an empathetic student who could take it forward. So my present PhD scholar, Ms. Tajinder Kaur, who very interestingly has also been a scholar of Professor Joshi during her MPhil times, working on her MPhil dissertation, which was on gender and disability. So she was very eager to join me in this pursuit. And this is the product that we have come up with. It is not a part of a major project or a minor project. It's just an endeavor, because anthropology of disability is wide, it's deep, but unfortunately, there's not much of literature available on the kind of theme we are working upon. So just to give you a brief introduction of the theme, disability and health. Disability and health is a major area of concern for anthropologists who are venturing into the study of a rapidly changing world where mind, body, intellect, ideas, emotions, values, and morals are in a process of rapid transformation, and the concept of self and others is gaining new dimensions with every passing day. Now, what was the rationale that we decided to choose this particular theme? Considering that both disability and adoption are regarded as social problems in India and are both attached to the notion of stigma that adds up to the vulnerability zones, we together felt that the problem of disability and adoption deserves to be explored in an anthropological light, especially in context of the special needs children, their prospective adoptive parents, in short, we call them as PAP, even the disabled PAPs who are just denied the rights of adoption of children in our country, India. The case seems very gloomy. So we thought of picking up this research problem in the belief that human potential, especially that of children, can be discovered and nurtured only when they receive a desirable environment of a home and proper parental guardianship. Now, coming to the research questions, we decided to explore a few simple questions. What are the needs and challenges of children with special needs in India? What are the adoption guidelines for such children? What is the role of a family home in the mental health and well-being of children with disabilities? And what are the suitable policy measures? What are the loopholes? And what can be certain suggestions that we as anthropologists can put forward? I'll introduce you to the objectives of the study. The first objective, to understand anthropological connotations of the terms disability and adoption. Secondly, to find out the various legislations, legal rules, acts, which are there in our country to help these children and the PAPs. Thirdly, to find out the mental health challenges of such adopted children. No quantitative study, but yes, a narrative analysis. Fourthly, to explore the social mindset of the general public and the civil society towards the whole problem of adoption. And lastly, to explore what are the policy measures and how much the government is confronting these issues. The methodology of the study, of course, it included both the primary and secondary data sources. In the primary data collection, we basically did a very small visit to two of the most renowned adoption centers of Delhi, one in the northern region of the city and one in the southern side of the city. I am keeping them anonymous as of now, though I have mentioned it in the chapter that I've presented in the book. These are, one of them is a government-sponsored NGO and the other NGO is in a public-private partnership. Now, these two NGOs are regulated by the guidelines of the CARA, which is Central Adoption Resource Agency. Now, before I come to the explanations of what CARA guidelines are, let me give a very small introduction to what is disability and what is adoption. Now, disability is a familiar term, and I'm sure you might be understanding that disability is not a disease. And the disabled in our country are designated politically correct term, the Divyang. However, across they are designated as the differentially abled, and this terminology had been given by the US Democratic National Committee in the early 1990s. At times, we also refer to them as special needs children because these children require special care, special attention. And though CARA has a different definition of special needs in which it categorizes these special needs children into 4 categories. This is important. Number 1, they are children who have serious or visible medical or physical conditions. 2, they are children who are very old. They are children who are siblings and they are orphaned and they are disabled. And the last one is there are certain children who have an extremely low birth weight. So basically, CARA qualifies these 4 kinds of children as the children who are disabled. Now, anthropologically speaking, like I said, anthropologists have contributed, no doubt, to the study of disability and anthropology, ethnographically, phenomenologically, and through cross-cultural methods. However, this particular area, disability and adoption, in foster homes or in the homes of the PAPs, has not been touched that widely in India. Maybe one reason could be the stigma and the myths that run around the whole theme. However, some studies have been done which take in account kinship theories relating it to adoption theories and the disability theories. I'm sure you might be knowing what adoption is, maybe not the definition, but the whole idea behind it. I'll tell you the definition of WHO. WHO defines adoption as per the Juvenile Justice Care Protection Act, in which adoption is defined as the legal process through which the children are permanently separated from their biological parents and they become the legitimate children of their adoptive parents with all the rights, privileges, and responsibilities that are attached to the relationships. Now, some small amount of data that I would like to highlight. Recent data is suggesting no absolute number of such kind of children. However, there is a tentative calculation. According to 2011 census in India, there are 78,64,636 children with disability in India. That constitutes about 1.7% of the total child population. Now, according to this data, which is actually the data of CARA, Central Child Adoption Resource Authority, a number of organizations come in to club up this data, like Ministry of Women and Child Development, Social Justice and Empowerment Ministries, etc. Now, something important that I find important in this data is that the inter-country adoption data is very specific. Intra-country is lesser. Inter-country adoptions range in the numerical zone of 355, 400, and intra-country, it's just 46. So you can imagine how critical is this whole aspect. Now, some of the main agencies that come in adoption are Like I told you, Ministry of Social Justice and Empowerment, Women and Child Development, and of course, CARA. And who are the stakeholders? The civil society, the NGO, the government, the PAP, and the children. Now see, there's a kind of a nexus between all these agencies. There are certain stakeholders of this whole, I would say, the blame game, a set of fears and anxieties, and credit taking. There is no central authority to take the leadership in this issue. CARA has its own definition that I'm not going to elaborate, but yes, it's the nodal agency. In fact, the prime-most agency that guides the whole process. Now, I'll inform you a little bit about the various laws which are related to adoption. One is the Hindu Adoption and Maintenance Act of 1956. And please note, it is exclusively for the Hindu citizens of our country, and Muslim minorities and Parsis just don't have any say in this act. The second act is the Guardians and the Wards Act. Now, this act doesn't mention anything about parenthood or childhood. It mentions about guardianship and wardship. So you can imagine the difference. The third act is Juvenile Justice Care Protection Act of 2000, which has undergone various amendments, 2006, 2011. And somehow this is a kind of an umbrella act, but still, I would not say it is the single standardized adoption law in our country. Now, what kind of guidelines CARA is giving for the prospective adoptive parents? In very short, it's their demographic profiling, their age, their sex, their educational status, their marital status, as well as it's a psychological profiling and emotional profiling. So I would personally say, by the narratives that I collected, I could realize that these PAPs feel just naked in front of the adoption agencies. Their secrets are out, their life is public, right? Now, what kind of efforts our government is taking? Our government is definitely coming in front and making the whole system of adoption of such children, even the disabled children as well as the general children, very open. Open in the sense, very technical. Forms are to be filled, and at one point of time, a prospective parent can choose from five children. And just on the basis of photographs and the biodata of these respective children, they need to make a conclusion. Who are they going to bring in their families? Now, this is very tough. And in fact, the adoption agencies are not liking it, because the adoption agencies are feeling that ultimately, if any problem happens, who is going to take the whole blames, plus who is going to take the whole responsibility? The government is not going to come up and take any kind of responsibility. So these adoption agencies feel that the process should be a little more flexible. But of course, considering the fact that there are so many cases where these children are adopted and later they are sent into child trafficking, or perhaps begging, or perhaps organ selling and all. So these adoption agencies are very careful and very critical of the whole process. Now, coming towards the conclusion part of the paper, where I look into certain policy loopholes. Number one, there is no single standardized adoption law in the country, as I suggested. Number two, the guidelines of CARA are often too subjective. For example, only the older prospective parents are more experienced to handle the disabled children. Now, this is a myth. For example, if somebody like me, I'm young and I'm eager to adopt a disabled child, I don't have that option. I might not be given a child. Other considerations like a single male cannot adopt a female disabled child. So these are a long list of considerations which takes a lot of time, a lot of paperwork, and the government is just silent in creating any sort of media awareness in this regard. Some of the narratives that really caught my attention was that some of the parents said that kharcha bahut zyada ho jata hai ek disabled ko ghar lane ka. This was one of the narratives. Second, adoption agency mein in bachcho ko dost milenge, ghar pe inke dost nahi hote. Number three, adopted children will run away from our houses before they turn 18 because they won't be able to relate to us. So these are various narratives which came up during the study, and they are mentioned in the chapter that I have presented. Now, just coming to the discussions in the conclusion portion that I would like to read out because it is significant. This whole exercise was based on the belief that human potential, especially that of children, can be discovered in safe and secured environment of families and homes. But in India, with growing trend of nuclear families and working couples in urban places like Delhi, the chances of adoption of special needs children by the childless couples reduces even further. Those who are in a joint family, they are very much worried about how will they present this disabled child in front of the other family members. The adopted child has equal rights on property, and sometimes they feel that if they are adopting such a child, who would take care of the property rights in future? Along with changes in government policies, we are speculating that the mindset of the people needs to be changed and more voluntary support groups should be created in our country, India. Parent resource materials should be prepared. But first of all, the primary task should be to restore the disabled child to their own biological parents so that their growth and development will not get affected by the frequent change of any foster home or undesirable environment. If these children do not know the concept of family or relative, how can they identify themselves in this big, large world? Concluding the study, we strongly feel that the government, these adoption agencies, they need to just loosen the grip over the guidelines that they have built around the whole theme, making it so much of technical. And more so, they should try to familiarize the people of India regarding this issue so that more people come up very openly and they admit the fact that they are willing to adopt the children who are marginalized in society. And in fact, it's an appeal to all the young anthropologists who are sitting there that if you get a chance, kindly try to explore anthropology of disability studies because we are indeed having a scarcity of it. In fact, we have a very big forum, the United Forum of Anthropology in India. It also discusses something very similar, that the whole idea of anthropology of disability studies needs to be explored more and more. So with this note, I'm giving an end to the presentation because I can see the time, it's 10:45 a.m. So I'm sharply on time. Thank you so much.
Yeah, Dr. Mitashri, you ended up your presentation sharply on time, and thank you for this brilliant presentation, and I wish you the best.
Thank you so much, sir.
And I invite Dr. Shivani Chandel, the moderator, to pick up the questions and that is in the chat box, or if anybody would like to ask questions, please, Dr. Shivani Chandel. I think that the Shivani Chandel has become offline. May I ask,
Sir, I'm here.
Okay, Shivani, please.
Sir, I'll give. I think we should devote only 5 minutes for this session because it's already 10:46. So there is this query by Surisnata Majumdar.
Chandel, Dr. Chandel, Dr. Vijaya is the co-chair. She may have some comments.
Okay. Dr. Vijaya? Dr. Vijaya, are you there?
Yes. Yeah, Shivani, I'm here.
Yeah, Dr. Vijaya, if you can say something about the presentations, any observation, anything?
Well, we have heard all the presentations, and I must say the three presentations were very, very insightful, and they have taken up very important social issues. The first paper was on adolescent mental health, taken up by Dr. Ulfat Mir. And I think it was it is a paper which is needed at this time when we see the situation in Kashmir, when we see the situation in Manipur, especially, where AFSA is imposed, violence take place every now and then, and, adolescents and every age group go through mental stress, trauma. And this paper was the need of the hour, I must say. And it has analytically brought out the situations adolescents go through and how we should tackle it. Another paper was by Dr. Chakravarti Mahajan. It was also a very insightful paper which talk about infertility of women and how they go through, mental stress. I must say there are the people who come to the, hospitals are quite lucky in a way. There are many people who cannot even come to the hospital or could not express their stress at home in village. People who have come, they are, at least they have the support for their family to come to the hospital and try to treat the problem they are facing. But there are many people who are untreated there also. The paper has also brought out how people go through stress, anxiety, and depression in different levels. And it was a very, very interesting and insightful paper. And another one was on, the last paper was by Dr. Mitashri Srivastava. Yes, disability and adoption. I was wondering when I first, heard the title, how disability and adoption can go together, because children, when as parents, when they think about adoption, they think about carrying on their heredity, carrying on their, generation forward. And how can they think about adopting a child who is disabled? Adoption itself is a big decision in the family. Coming to the point where they want to adopt a child is a big decision. And how can they think about it? It's a very, very, interesting, at the same time, contrasting kind of situation I felt. But when she expounded the paper through, I could understand how there are people who are willing, but because of certain issues, because of the technicalities involved in adoption, people are not able to come out and even adopt the children, even if they are willing. This, I must say, all the three papers have given us a lot of knowledge and enlightened us. I'm very thankful to the, presenters. That's it. Thank you.
Thank you so much, Vijaya. Now I request Professor Shubore to say his observation. And
No, I have already made my observation on each paper. I've just because there are some few questions, I request the organizers to give some time, at least 5 minutes, because we started 5 to 7 minutes late. So
yes,
yeah, please.
I will very quickly.
Person can take the questions, na? Instead of the moderator. Moderator, I think chairperson only can take the questions.
Okay.
You can.
Then I have to look at. Achha, there was one question by RP Mitra Saab on Dr. Urfat.
Yes, Professor Ray, if you allow me, I would like to respond to that.
Yeah, please.
The question was actually about, the individual resilience and the collective resilience as a process, that how is resilience at cultural level distinct from individual resilience as a process. To respond to this, I would actually, begin with an example, from one of the findings of a study that I actually carried out as part of, my PhD work. Now, where I was trying to actually look at the impact of violence on adolescents, at the same time, I was also trying to look at that how, this violence was impacting the community as a whole. Now, in my field work, what I observed was that, for the narratives that I, gathered from the field work, in two distinct, geographical and cultural settings of the state of Jammu and Kashmir, when the incidence of the militancy was at its peak, what was actually happening at that point of time was that there was this pursuit of the militants by the armed forces as well. Now, as a consequence of that, there was this collateral damage on one hand. At the same time, there was also this unleashing of atrocities, by the militant forces, and at times, by the security forces also who were actually pursuing these militants. Now, what was happening as a consequence of that was that, especially in the rural areas, one, that there was this mass migration which actually took from rural areas to cities, towns. The other was that those couldn't actually migrate. What could they actually do? During the daytime, it was usually easier for them to actually, deal with it. But at night, because most of these operations would actually, take place under the cover of the darkness. Now, what would these community members do? They would actually assemble at either in a village at one villager's house, and especially in one of the field areas, there was this one very famous local shrine, of a Sufi saint. That shrine which actually, offers lunch, and food, to the pilgrims who actually visit that. Again, a shrine that actually has pilgrims from, across communities, across religious communities from the state and outside the state as well. And interestingly, the Sufi shrine, the Sufi saint who is actually there is supposedly, supposedly has actually come from the other part of the other side of the border, fine, even before the partition, but then he has settled it. So what they would actually do is that, they would actually assemble there. Now that assembling there at house of an, one villager or at the religious shrine would actually provide an opportunity for, all of the community members to assemble at one place, and they would generally spend their night hours discussing about various issues. Because of the space constraints, it was a kind of a situation where, people across age groups, adolescents, children, adults, and even, across genders would be actually, accommodated in a very compact space. But at the same time, this narratives discussing about the situations, and also putting up some sort of a resistance or a safety network was something which was actually developing as a very important.
Dr. Mead, be brief because we are running out of time.
Okay, thank you. So what I'm essentially trying to say is that, it was there that religious healing or religious place providing a space for the locals to assemble, to share, to provide a cushion effect. At the same time, the adolescents were actually finding some kind of an outlet, through which they would discuss with peers, they would enact, the plays of the traumatic events. On one hand, where trauma was very severe, painful, yet at the same time, discussing traumatic event was actually considered very normal in the, literal sense. The last point here is that, it is somewhere actually what is important here is that it is this cultural resilience, which also can be seen in the way that individuals respond to it. While the diagnostic model of the Western societies is trying to actually portray it as individual mediating or confounding factors, in which individual experience of the traumatic event is constructed as, an ability to overcome an adverse situation. But I think in our context, it's the social cultural resilience that is more important. Thank you.
Thank you so much. There are two questions for Dr. Chakravarti. One is, being issueless and being infertile are two different things. Infertility among humans is rare. Not bearing children may be more often due to incompatibility. A quick short reaction or respond to this question, Chakravarti. Please unmute yourself. Please unmute yourself.
Sir, I think what has been said, it may be true, but I have very little knowledge about, whether humans are, we don't have any information available. We have information available on the rate of infertility, which is increasing over the years. But I do not know naturally in a natural state whether human beings are, infertility is a condition which may emerge due to many confounders. There may be many reasons for infertility, for both male infertility as well as female infertility. Of course,
that's true. What you were saying, that the concern is about the stress. So it's not the reason behind infertility your project is dealing with. That's true. That's true.
Okay.
Chakravarti, there is another question.
I think you can answer both the questions better than I can.
No, histocompatibility, there can be many other factors, but your presentation or your project is not dealing with this, perhaps. The second question is, anxiety is very much situation specific, consequence specific, time specific too. Further, it depends largely on age and sex of the individual too. I am very much eager to know how you how you have leveled such a relative issue as mild, severe, and very severe, and likewise.
Sir, I think that is because we used psychological tools which have a very, very structured format. And we calculated scores as they prescribed. So that's how we reached these levels. No other, we did not devise them ourselves.
No. There are scores and there are cutoff values on which we can do it.
Yes.
Okay. I thank to all the speakers, to the participants, to my co-chair, to my moderator, and finally to the organizers for giving me this opportunity. And we had a nice session. And I apologize for dragging the session 13 minutes more, but we started 7 minutes late. That's true also. Thank you so much.
Before ending the session, I would really like to thank our chair, Professor Shubore, and our co-chair, Dr. B.S. Aribam, for taking some time out and chairing this session. Thank you so much. I would also like to thank our three participants for giving brilliant presentations. And I would request them to just check the chat box once if there is any question which we might have overlooked and answer it. Thank you so much. Thank you so much.
Good morning, everyone. The next session is women's health and well-being. I just want to check whether our chair, yes, welcome Rumi ma'am. And then our co-chair, Dr. Hemlata, I just want to check whether she is online or not.
I'm here, Kiran.
Oh, thank you. So I would like to welcome our chair and co-chair, and both of them are very renowned anthropologists, and I know them very well. Professor Rumi Dev is a professor in MIT Institute of Anthropology, and she has completed her PhD from our Department of Anthropology, University of Delhi. And the co-chair, Dr. Oinam Hemlata Devi, she completed her master's and PhD from our Department of Anthropology, University of Delhi. And she is presently assistant professor in Ambedkar University, Institute of Human Ecology. So I welcome both of you, and we have, I think, 5 or 6 speakers in this session. So over to you, ma'am, and Dr. Hemlata.
Dr. Kiran.
Yes, sir.
There was a session in the program, session 5th, women's health and well-being.
Sir, this is the session.
I'm sorry.
This is the session which you are talking about, sir.
But the thing is that the name of the moderator, chair, and co-chair, are they changed? Because in the program, the names are written, different names are written.
Dr. Mandal sir, the copy that you have is the older copy. This is the latest version.
Okay.
Okay. There's a confusion. There were many copies, and final version is the one which we have now. I think you have an older version.
Okay.
Sir, I'll share the copy with you right now.
So over to you, ma'am, and Dr. Hemlata.
So good morning, everyone. And nice to see you again today. Yesterday, I had a nice understanding of the subject which we listened yesterday and presented a paper. Thanks for inviting me to chair this session. And I'm always happy to be here, and especially in this prestigious seminar, which is held in honor of Joshi sir. So it's more an honor for me. So I would just like to start, because I think we had to start at 11:45 and it's almost 10:45 and it's almost 11 now. So today's session is on, the present session would be on women's health and well-being, where I think with the presenters here, we will be having a very good deliberations and we'll have a good understanding of the subject, because women need healthcare as well as access to healthcare system, which is very, very important to understand. And for their well-being, they also need access to healthcare system. And these are the key in maintaining healthy families, because women are the people who are the key in maintaining healthy families. So access to healthcare system is very, very important. And without any further delay, I would like to start the session. And I would, the speakers are whom I'm seeing the name are very competent and good speakers whom I know them. Most of them I know personally. And I think we will be enriched and enlightened by their deliberations. So without, and thank you, Kiran Mala. And the co-chair is Dr. Oinam. Let's all start the session. So without any delay, Dr. Saraswati, you can start, Professor Saraswati, you start the session, please.
Ma'am, with your permission, can I just inform a small thing about the timings of the presenters?
Yes, please do. Please.
As we have a total of 5 presenters in this session, if I correctly check the available timing, I think we have around 2 minutes, 2 hours, 2 minutes, or 2 hours, 10 minutes. And so probably if each of the speaker maintains 20 minutes maximum, then we can get around 15 minutes for discussion. So please stick to the time of maximum 20 minutes. Thank you.
Thank you so much, Professor Romi and Dr. Hemlata. And Hemlata, I'll try to stick to time. Okay. Today's a very good morning to all of you whoever is attending here, all the seniors and the senior professors of the department, and also the people who have online who are not presently in the department, but they were a part of the department somewhere back, like Professor Marva, I see him on the screen. And today's topic is folic acid supplementation in pregnancy, an anthropological insight. And I have, in almost all my talks, whenever I give a talk anywhere, somewhere or the other, I try to bring up a small bit of this topic somewhere or the other. This is my favorite topic. But whenever I had a discussion with Joshi sir, he always used to say, this is an important public health issue, Saraswati. You need to bring it to public, and you need to work more to bring awareness. And also you have to let the policy makers know about this. So, but I didn't know how to do it. I'm just an academician where I only work with my students. I don't know how to disseminate things. So I thought maybe in his honor, when I'm giving a lecture today, when I contributed a paper, let me talk on something which is, I have been discussing with Professor Joshi all the time. So here, folic acid. First of all, let me just understand what during pregnancy, folic acid is given. Everybody knows. Every woman must have taken folic acid during her pregnancy. So everybody, all women and their respective husbands, they must be knowing about folic acid. Now the question is, what is folic acid? It is one of the micronutrient which effectively participates in one carbon metabolic pathway. There are many pathways that keep us alive. And one of the pathways is one carbon metabolic pathway, which is driven by folate, that is folic acid, and also methionine. So two pathways together, they get together, they're called as one carbon metabolic pathway. And this pathway is important for two major reasons. One is it provides some raw material for genetic mechanisms, and it provides some raw material, in fact, the whole raw material for methylation epigenetic mechanism. Why are epigenetic and genetic mechanisms important during pregnancy? What is pregnancy? Pregnancy is something, a single cell zygote develops into a multicellular fetus, a baby. And in this, two things are happening. One is cell division, where cells are increasing in number. The second is cell differentiation. And cell differentiation means that every cell has to become some part of the body. So they should know which cell to become what. So in cell division, DNA division is nothing but DNA replication. So cell division has to have will result in DNA replication will result in cell division. So DNA replication may you need to have raw material for DNA, and that is one of them is produced by this particular pathway. Second is methylation. Methylation is the major one of the reasons. There are many other epigenetic mechanisms which which switch on and off genes, or which increase gene expression, which decrease gene expression, and one of them is your DNA methylation, and the methyl groups for DNA methylation are exclusively produced by this particular pathway. That means both cell division or cell growth in number and cell differentiation, both are somewhere or they contributed by this particular pathway, and this pathway is driven or governed by folate. So folate is very, very important. So folate supplementation wide, and this particular one carbon metabolic pathway is not only driven by folic acid and folate, but also some other enzymes, some other micronutrients like vitamin B12 and B6, and some genes like MTHFR, MTRR, CBS, many other genes are also there. So mutations in those genes and deficiencies of these micronutrients, they do affect this pathway, in turn affecting the cell division and cell differentiation. So this pathway is very crucial and important and vital for during pregnancy. And why this folate supplementation of all these different vitamins vitamins present in this pathway, why people have chosen to give folate to people? That is the first reason. Because in European and Western countries, the research up to maybe 1990s, everybody supported folic acid supplementation because it is supposed to be, there is a ample evidence which talks about the effect of this folic acid supplementation on the reduction of a congenital malformity called as neural tube defects, NTDs. What is an NTD? It is a spinal cord malformation, and then resulting in some cranial problems. And then it is because of the non-closure of the neural tube, the spinal cord, neural tube. So these things, to prevent neural tube defects, there is a good evidence that folic acid would be helping. And this research mostly was done in Western countries, and their folic acid deficiency is very quite frequent. And so they said if you supplement women with folic acid, they will be protected from this neural tube defects. And there is ample evidence. There are so many references. I am not going to go into details because of Hemlata. She is very strict about timing, she told me right now. So now let me just talk to you about after 1980, 1990, till then, people were very convinced about folic acid supplementation, and people also believed that folic acid is definitely a water soluble vitamin. Even if you take in big doses, it doesn't matter, it will be washed off from the body. That was the belief they had. But the research after 1990s, that is giving a different story, where people are coming up with the ill effects of extra doses or overdoses of folic acid. And here I would like to give a few examples. Like before going to bad effects, there were some countries which have done fortification of cereals. I think the first country to achieve national scale fortification of flour with fluoric acid to prevent NTD was Oman. And in 1998, Canada and also United States. And there are many more, 70 countries have adopted this fortification of folic acid. And they have tried to reduce, 31 to 58% of reduction of NTDs in those countries. This all happened in 1995, 96, something like that. Later on, there is a big problem, and they started saying there is something going on with this high folate given to people. People felt that there is something going wrong. So people started working on that. And then there came evidences which talk about the bad effects or adverse effects or ill effects of folic acid. Indiscriminate supplementation of folic acid was found to be posing risk for other serious diseases and nutritional deficiencies. If you give more folate, there are other nutritional deficiencies and other serious health adversities. And also they also said, worldwide have concluded that folic acid supplementation has no effect or little effect on the fetal outcomes, very little effect on the fetal outcomes. And they also said it is not helping to prevent cardiovascular diseases. And most importantly, I have at least 10 to 15 references where they have talked about the risk of, the future risk of both child and the mother with high doses of folic acid during pregnancy. Because again, I'm not going to give you references and details of that. Even meta-analysis studies have shown that increased prostate cancer risk if there is high folate in blood. That was also proved. And later on, they also said in this particular one carbon metabolic pathway, along with folic acid, there is another vitamin called as B12. And of course, B6 is also there. And B12 deficiency is masked by the high doses of folate. If a woman has B12 deficient, if it is continuously taking high folate, B12 deficiency is marked. And B12 deficiency is a very important marker for good mental health. If deficiency is there, mental health problems or neurological problems are likely to be developed. So these are the issues that basically high folate first thing is no positive effect on fetal outcomes. Second, cancer risk. Third one is, there is no prevention from cardiovascular diseases. Fourth one is mental health issues. There are so many mental and physical health issues, both at maternal and fetal level, if folic acid is consumed in high doses during pregnancy. This is the recent literature for the past 20 years. That means for the past 40 to 50 years, people have been given folic acid. After 50 years, the long-term data has found out that there is again a risk of cancers. Cancer is the major risk with high folate. Because it is a long-term thing. Now I consume during my pregnancy. After 20 years, I have a risk for cancer. That means that is through epigenetic mechanisms. So it is hidden now, but it comes out a bit later, late age of onset. So that is very, very important. Then when you talk of high intakes of folate, there are so many complications. And I told you there are certain mutations in certain genes. If there is a mutation also, there will be some problem in the pathway which can affect an epigenetic mechanisms. And mutation for having B12 deficiency will have again a problem. Mutations and overfolate again a problem. So these are the various issues which may make things complicated during pregnancy with folic acid. And especially during pregnancy, when we talk of pregnancy, mother's health, mental health, physical health, emotional health, psychological health, they all, social health, all are important for the proper development of the baby. And then biological health is majorly decided by your nutrition. And nutrition, of course, everybody takes, but this folic acid and iron is the first external stimulus to the baby. It is the first external, something artificial you are giving to the mother. Folic acid is an artificial form. Folate is a natural form where you get it through green leafy vegetables and other vegetables. Now in this, so now here I'm not saying folate is a bad or good. Folic acid is good just to prevent neural tube defects. But giving folate to each and everybody, even if they are folate replete and folate sufficient, that is bad. So this is the question. Based on this question, we conducted some research projects in anthropology department in collaboration with Lady Hardinge Medical College and Srimati Sucheta Kripalani Hospital. And here there are some interesting things. First interesting things I would like to tell you is, like in this folate metabolic pathway, there is a metabolite called as homocysteine. Homocysteine is inflammatory marker. Now in this COVID situation, everybody knows what is inflammation. Inflammation is something bad. So the higher the homocysteine, the higher risk for all the diseases, whether it is pregnancy complication, whether it is cardiovascular diseases, whether it is mental health, for anything, high homocysteine is bad. So high homocysteine is supposed to be happening when there is a mutation in the gene in the carbon metabolic pathway, or where there is a deficiency of the nutrition. But unfortunately, in our study, we found homocysteine was found to be very, very high in spite of very good doses of folic acid. Even the women who have pregnancy complications, be it intrauterine growth retardation, be it preeclampsia, be it pregnancy-induced hypertension, be it gestational diabetes mellitus, be it spontaneous abortions. Any pregnancy complications you name, the homocysteine levels are so high as compared to the controls. I mean, folate and still the folate levels are very high. In spite of high folate levels, their homocysteine is very high, and the homocysteine associated with all the pregnancy complications. That means somewhere or the other, high folate indirectly is associated with bad pregnancy outcomes. But the problem here is we were not able to associate folic acid sufficiency or deficiency with the pregnancy outcomes, because all the women who come to whether pregnancy complication women or normal women, once you come to hospital, the gynecologist is bound to give her folic acid. So they are all folic acid. 98% of cases and 98% of controls are folic acid sufficient. So we are not able to find out deficient people to really understand the effect of low folate, high folate on pregnancy complications. That is one important thing. Second important, we also found that B12 deficiency. B12 deficiency is found to be significantly associated with all the pregnancy outcomes I just mentioned now. And B12 deficiency in light of high folate is more affecting the pregnancy outcomes. That means B12 deficiency is quite important in this, and that is being masked. And here in Indian context, both B12 and these are important, but B12 is not given, folate is given. Whether you are folate replete, whether you are folate deplete, or whether it is sufficient, whether it is insufficient, you are dumped with folate. Okay, so that is very dangerous and very lethal. And then I have not much detail I'll be going. And there was a small study we did a follow-up study on 100 pregnant women. And when we saw before giving them folic acid, when we measured their folic acid levels, more than 80% of the women were folate replete, and more than 65% were B12 deficient. But so what should be given to them? They should be given B12, not folate, but we are giving them folate because Western countries have asked us to do that. We have been doing, and we are giving. Our problem is folate, not folate deficiency. Our problem is B12 deficiency, but we are giving folate to those women who are already folate replete. So this is quite an important thing. And then just here see, that with the notion of preventing NTDs, neural tube defects is one of the thousands of congenital morphologies. Is only one congenital morphology. To just protect people from NTDs, you are giving them people folate, and you are making them prone to many other diseases. Maybe they are. I mean, even if they are deplete only, you are protecting them. Even if they are replete, you are putting them more at risk for other diseases. Preventing NDDs, several pregnant women are getting exposed to high intake of folic acid, rendering the individual susceptible to complex disorders. So this intervention is expected to reduce pregnancy complications, but with pregnancy complications are found to have excess circulating unmetabolized folic acid levels in their blood. This is something very dangerous. Now coming to the 3 or 4, how much time is left, Dr. Hemlata?
You have 3 minutes only. I was about to remind you.
Let me just come to some sort of conclusion type. 3 or 4 important points I would like to highlight. First thing is folate deficiency. Folate, how much you have to give. The recommended dose by WHO to pregnant women during the first trimester is 0.4 milligrams, that is 400 micrograms. Okay, all the developed countries are giving 4.4 milligrams or 400 micrograms. But in India, Bangladesh, Pakistan, these third world countries, we are giving all pregnant women 400 5 milligrams, that is 5 mg. 5 mg means 5 mg, that means 12.5 times higher dose as compared to the WHO recommended dose. That means very, very high doses of folic acid is being given to pregnant women. Number one point, that is very, very dangerous. When I spoke to one of my UK collaborators, she almost fainted. Then second important thing is, usually in Western countries, once they get married, they keep talking to the doctor, they plan their pregnancies. Before the pregnancy itself, they take the tablets, I mean folic acid, to prevent neural tube defects. But in India, nobody goes to a doctor till they are pregnant. Once they think that now the one or two we miss the menses and the menstruation, and then they go. That means you reach the doctor after one month or 1.5 months. By then the neural tube defect is closed. If the neural tube is closed, that means that is the time 1.5 months. And if the neural tube has to happen, defect has to happen, has already happened. If it is not to happen, it does not happen. So you are giving folic acid after 1 or 2 months of pregnancy, it doesn't really affect the neural tube incidence. That is second point. Third important point is, we are following the Western countries. In Western countries, breakfast, lunch, dinner, everybody follows non-vegetarian diet exclusively. And it is also not so cooked with all types of spices. It is a very crude raw meat they eat, and that gives them a lot of vitamin B12. But in Indian context, vitamin B12, the major source is non-vegetarian diet and fish, whereas in Indian context we are majority are vegetarians. Even if they are non-vegetarians, they don't consume non-vegetarian diet daily because of cultural reasons, spiritual reasons, religious reasons, economic reasons. They cannot afford to eat non-veg. So majority, you can say 80% are non-vegetarians, vegetarians, even if they consider themselves to be. So most of the time, when we have conducted a study and seen in different populations, B12 deficiency was to 65 to 70%. But folate deficiency is only 25 to 30%. And in such a population, in Indian context, where women are not folate deficient, but B12 deficient, we are giving them folic acid in not only in normal doses, supra physiological doses, and we are putting them at risk for future other diseases, including cancers. So this is what it is. Thus, folic acid supplementation to folate replete pregnant women is debatable in India, where this program is being implemented since 1970s. That means it's more than 40 years. So this is something very, 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 very crucial one has to think, and robust studies have to be done in India, where you develop good evidence that folic acid, high folic acid is not good. But we don't have any studies, and we have developed a project and submitted to various funding agencies. Everywhere they reject it. I don't know the reason till now. So now I think this is a platform, at least if I'm able to reach to few of the audience listening to me here, and then some people, we have to pick up this. And very few people are working in India on this 1-carbon metabolic pathway. And if they are working on B12 deficiency. It is not folate deficiency. Folate they have taken for granted. Folate has to be given. So any pregnant woman, I mean, now LHMC doctors, after doing research together in collaboration with us, they reduce the folate doses now. After our research findings, but these research findings have to be come to the public. I don't know how to go about all these things. And moreover, important point is, any metabolite, folic acid is an artificial form of folate. Folate is a natural form. Any natural and artificial have different forms, different routes to metabolize. So that is important. Today I am talking about folic acid, but I am also referring to all the other micronutrients and vitamins. We indiscriminately take vitamins. Becozin chlelina, you take Becocil capsules, anything, you are feeling weak, some vitamins you take. That is a very, very bad practice. Unless you are deficient of something, you should not take that. That is what I personally believe. I think I'm able to convey what I have to say. I had to say so many things, but I think 20 minutes were too less. Anyway, thank you so much.
Thank you, ma'am. I'm so sorry for putting you this much of pressure to finish everything in 20 minutes. It was really insightful, and I think you have given a proper justification to your topic, because your topic itself says an anthropological insight, right? So there are also comments and appreciation coming up in the chat box. But what I feel is that if Rumi ma'am permits, then we should take all the presentation first, and then ma'am, can we have the discussion after all the presentations are done?
We should go ahead with the presentations, and
yes,
then on
yes,
we'll take up the
yes.
question
So
once all the presentations are done.
Yeah, but I request
Dr. Saraswati, I've learned a lot, Professor Saraswati. Chalo, let's go ahead.
Oh my God.
Yes.
Oh my God.
So next presenter is Dr. Bipin Gupta and Sastev sir. So the topic is definitely uploaded on the screen. So social epidemiology of maternal and child health in India. So over to you, Dr. Bipin.
Good morning, everyone. Good morning to the chair, Professor Rumi Dev and Dr. Himlata. And thanks to the previous speaker, Saraswati ma'am, who has already primed the audience after discussing the biological aspects of pregnancy. So I can conveniently discuss the social aspects of maternal and child health in India. So social epidemiology is basically very understudied aspects of maternal and child health. If you look at the global landscape of social epidemiological studies, in any aspect of disease or especially with respect to maternal and child health, this is a very narrow focus of epidemiologists or public health scientists or even anthropologists to what they call them social factors, or how they define those social factors and how to measure those social factors. The biggest challenge in social epidemiology is to convert those subjective measurements, subjective variables, to more and more objective or measurable variables. That's the biggest challenge. So I will discuss some of the major aspects related to the culture, society, which can directly influence the maternal and child health in India. Now, why maternal and child health is important? It's because maternal and neonatal disorders are the topmost, the second topmost and 8 topmost reasons of morbidity and mortality in India. As you can see, the 5% total deaths and almost 10% of deaths are attributable to these disorders. Deaths are disability adjusted life years, which means how many years people have lost due to disability. So almost 10% of the total disease-related deaths are attributable to maternal and child health in India. And out of these, if you look at this 100%, then out of these, almost 4% of total deaths, or almost 9% of deaths attributable to low birth weight children and short gestation period under maternal and neonatal disorders. Not only that, there are factors like related to child health, like prevalence of stunting, almost 16 to 64% in India. And the range is so big because of the local variations with respect to the different states. In some states it's 16% and highest is 64%. So all these factors actually makes India very vulnerable, especially this section of this category of people related to maternal and child health. They are very vulnerable section of the society. So which is why this is important to focus upon pregnancy disorders, maternal and child health. And then if you look at the top global causes, top cause of global maternal disability. So and if you compare 1990 data with 2017 data, you'll find that obstructed labor and uterine rupture are still the topmost factors for maternal disability in India, and followed by maternal hypertensive disorders, which is preeclampsia and eclampsia, and Saraswati madam already discussed and already have done a lot of research on that. And so these are the 2 prime factors, but there are many social factors which underlies many of these maternal or child health related disabilities, which I'm going to discuss. Why social factors? Because there's a complex interplay of various social factors which determine the overall maternal and child health in society. Majority of studies have focused on socioeconomic position because it's a proxy for measuring the poverty at the household levels, and it actually influences the maternal circumstances related to the material aspects of the household, for example, living conditions, working conditions, or food availability. All these are related to the poverty or socioeconomic status or the position of the household within that culture, within the society. Then social class and gender or ethnicity, they also determine the behavioral or biological factors, for example, mating patterns and various family dynamics, the entitlements of the woman, and you can say the inequalities within the household, within the society. So all these factors actually also influences the education of the woman and occupation, income of the household, and overall they can lead to psychosocial factors or mental disorders within the society. And cumulatively, they all determine, have good impact on, I mean, high impact on determining the health and well-being of the society. Because these factors are not very equitably distributed within the society or the culture. So differences within the distribution, differences due to the distribution of these, you can say, unequal distribution of these factors actually determine the maternal and child health in society. Now, one of the foremost and the well-studied factor is the culture and the caste. So culture norms actually are the deciding factors, because culture decides you can say the duration of the breastfeeding, when to introduce supplementary food to the child, whether what kind of support a woman need during the first month after delivery, what are the I mean dietary factors, I mean, or you can say the availability or entitlements of the within the household to the woman. And caste and ethnicity also play a role in determining the access to the health schemes available in the society or provided by the state government or the central government, the services or the schemes for maternal and child health. The studies have shown that usage of healthcare services was 3 times more in the upper caste women than the lower caste and women. These services may include the antenatal care services, birth attendance, contraceptives, medicines, ultrasound, sonography during pregnancy. All these services, there is a differential, you can say, changes or differences within the a different state of the society due to culture and caste, and services. I mean, availing these services is highly impacted by both culture and caste. And it has also been studied by the researchers that a child belonging to lower caste or tribe has a lower probability of birth registration, which means he or she, children who are not registered, they may not get those vaccination services or those followed by the Anganwadis women and other government schemes. They are refrained from those services. Then this culture also determines the adolescent pregnancy. And if you look at the data in India, you'll find that 31% of the married Indian women gave birth by the age of 18 years, which means there's a high tendency of getting married before 18 years of age, or adolescent marriages or child marriages are highly prevalent. And it determines the maternal nutrition status. Because of the lack of nutrition status, they may not carry the fetus properly, and it may lead to abortion and various other pregnancy complications. Not only that, adolescent pregnancy also influences the access to nutrition health services, because it's illegal, it won't be allowed by the government, which is why they are afraid of going to hospital and getting these services. Then it also influences the infant and young child feeding practices within the household, because they have to hide the child because of the social stigma and many other living conditions. And it also hampers the child's education and women's bargaining power in the school for getting good quality food for the child or getting proper education for her child. So all these factors cumulatively hampers the child growth in the end. And data has shown the stunting and underweight were 11% more prevalent in children born to the adolescent mother compared to the adult mothers. So there's an overall inequality to the in terms of getting health services, health access, health facility access, and various other social, you can say, social positivity. So they may not get those positive factors which other women may normally get it. So there's an overall gender inequality, and gender inequality in social epidemiology, you say that it's actually basically the social production of the gender which is dangerous, because biologically. Biology is very balanced in terms of both the sexes, but it is basically the social production of gender which is dangerous. And if you look at the 3 basic factors, the safe environment, protection, and education, they varies from birth to the adolescent and to the old age if you look at the life trajectory of an individual, you'll find that safety environment is different for the child at the time of birth or infancy level. It may vary at the childhood level when he's grown up enough to go to school, and of course it varies significantly when at the age of adolescent. Similarly, the education requirement and the transition to employment at the age of adolescent or later on, all these factors are basically you can find the gender inequality in all these stages of life. And when there is gender inequality since the beginning of the life, it will definitely hamper the overall health of the woman. And so these are the gender system or gender social position actually lead to gender pathways of health. So this is overall how gender influences the gender inequality, hampers the woman's health or maternal and child health, or leads to more morbidity or mortality at this level. So, for example, in safe environment, need for energy, water, sanitation, hygiene, mobility to within the local areas or out of local areas, then conflict within households, and of course, disaster is one of the component of safe environment. With respect to protection, of course, sex preference, way to marry, legal, financial, social protections, harmful practices within the society, exploitation by the neighbors and neighborhood and various other employers. Then in terms of education, school participation will be low if there is a gender inequality. Then school environment will be perceived as a very different environment in comparison to the male child. And then access to the information is also varies because of gender inequality. All these factors cumulatively influence the health outcomes with respect to child health and development, food insecurity, psychosocial well-being overall, and the health behaviors. Health behaviors are the behaviors are actually health-seeking behaviors. For example, if a pregnant woman may go to the for institutional deliveries, or may go for the home deliveries, or may have access to the medicine, or may have access to the antenatal care, or various other social services provided by the government during the pregnancy and for the care of the child, may not be accessible to the woman if there is a gender inequality in the society. Then there is another factor is urban versus rural factors, and studies have shown that these factors, these urban-rural differences influences the rate of institutional deliveries, which means in rural area there's high number of home deliveries, which are actually leading to neonatal deaths. And studies in northeastern states have shown the high disparity in institutional deliveries. Then differences in the level of urbanicity, which is actually what are the built-up environment around your household, and socio-cultural economic changes happening due to urbanization. It also associated with the adverse maternal and child health outcomes. One of the projects in which we developed in Andhra Pradesh, which is Andhra Pradesh Parent and Children Study, we have shown that rapid urbanization has potential to influence the cultural practices, especially with respect to the breastfeeding. So wherever there is a rapid level of urbanization in the villages, this is actually statistically associated with the shorter duration of breastfeeding. And shorter duration, for example, WHO's recommendation is for up to 24 months, and after 6 months, one has to introduce supplementary food. But because of this urbanization, rapid urbanization, we have seen in those 25, 29 villages, what we have seen that women have started the formula milk, or they are not giving breastfeeding up to after 3 months or 4 months or so. So these rapid urbanization is always unhealthy. The gradual level urbanizations are good for the society, and it will have more benefits to the women or other disease related aspects than the rapid urbanization. Then urbanization is there, then of course it's rapid urbanization or it's gradual urbanization. It will always lead to higher education. But if you look at the overall average education of women, it's just 7.7 years. And it has been shown by the studies that health-seeking behavior is more common among educated mothers than the uneducated ones. And of course, even in spite of good education, there's no surety that she may get the medical facilities, because its decision-making process is highly contingent upon the household environment. It is also associated, the maternal education is also associated with the range of child health outcomes. For example, child's nutrition, is vaccination, the morbidity and mortality, understanding of this, and then access to the nearby primary health center for getting the vaccination or getting the medicine for the child in case of diarrhea or any other problem, infection. And children of poorly educated mothers are greater at risk of stunting due to inadequate dietary habits. And of course, mother's education means generation is educated. If mother is not properly educated, of course, child education will also at stake. And when education at stake, it also hampers the child's career. And education, the most important aspect of education is it empowers the woman for making her decisions or exercising her choices and to exercise the control in the family. But again, if mother is educated, she may have a relatively more, you can say, freedom or leverage to make those decisions. But again, it's depending upon the family dynamics, overall family dynamics or the household dynamics. So family dynamics is another factor which is a big social unit, and it has deciding role in multiple aspects of the arrangement of the women health and related issues. So, and there are several aspects of family dynamics. For example, a number of, you can say, sister-in-laws in the household, relationship with the mother-in-law, and number of visits to the native household, to her own mother, she's allowed. Then economic status of her husband, then economic status of the entire household, distribution, entitlements within the household, access to those resources which are required for managing the pregnancy and handling the child, support system available. All these things are actually are the part of the family dynamics. And then prioritization of the if in case of poverty, of course, the food is limited, then there is some sort of prioritization of sharing of the limited food. And when the food is limited, of course, a mother may not get sufficient food for herself, and child may also get the less nutrients, and pregnancy may end up in abortion or subabnormality maybe. Then family dynamics also associated with the usage of maternal health services like institution versus home deliveries. You may want to get your child delivered in hospital, but your mother-in-law may not allow you to do that, and in the end you will end up in home deliveries. Then health expenditure, it depends upon household socioeconomic status and the poverty level. How much expenditure a household may make for managing the pregnancy. Then support system during the pregnancy, as I've already discussed this. Then there's another big important factor is domestic violence, because family dynamics also determines the domestic violence. If you look at the worldwide data, 1 in 3 women experience physical or intimate partner violence. And this could be, you may find it, oh, this is a big number. I mean, it may be exaggeration. Even if it's exaggeration, I mean, if it's not 1 in 3, if it's 1 in 10, then if it's 10%, even then it's very, very high. And mother's experience of, any kind of abuse is associated with high risk of fetal death and low birth rate of the child. And not only that, it also leads to the childhood stunting, poor education, and various adverse health outcomes like maternal, for example, during the adverse outcomes related to the pregnancies are preterm birth, premature labor, infant lower birth weight, and then small for gestational age, in terms of the birth size of the child. Serious injuries and disability to the woman, and of course, it leads to depression and thoughts of suicide are also there. And then high incidence of postpartum depression. Postpartum depression is a very well studied. From last 10 years, people are focusing on this, and it has been observed that domestic violence is directly associated with the postpartum depression. And for example, husband's lifestyle also determines the level of domestic violence, because husband consumption of alcohol or smoking is associated with greater risk of experiencing domestic violence or abortion during pregnancy. So these are some of the factors which I have discussed, and thank you. And the data says that motherhood, although there is almost more than 24% reduction in maternal mortality worldwide, but motherhood is still deadly. Almost 200,000 deaths are reported every year. And we are trying to answer, since the cohort, we are developing the GERB cohort, we are developing Rajasthan Bikaner, and we are trying to answer all the issues which I have discussed in this presentation. We are getting data in every aspect of it, and we may publish soon on that. Thank you.
Thank you, Dr. Bipin. It was really insightful. I would say that you have covered all accounts of different parameters in understanding social epidemiology. I really enjoy. You have also started getting questions in the chat box, but I think we should take all these questions at the end of the session. Yeah. And I request all the viewers to put your question in the chat box. So we take the next presenter. Next presenter is Dr. Meenakshi. Her topic of presentation is quality of life assessment among women in Koshi flood affected areas. Dr. Meenakshi, are you around? Yes.
Yeah.
Yeah.
Thank you,
So
Hemlata
please
ma'am.
carry on. Yeah.
Warm good morning to all of you. I am audible, I think. Hello.
Yes,
Yeah,
yes,
I am.
you are very
Okay.
much audible. Yeah.
Okay. So warm good morning to all of you. And today, at the outset, I would like to thank the organizing committee for holding this prestigious 2 days national seminar and providing me an opportunity to talk and give my views on this. Actually, it is an honor for me also. And further, I would like to extend my heartfelt gratitude to Joshi sir from this platform. Actually, when I was about to join my PhD, Joshi sir was nurturing and flourishing his disaster school of thought within medical anthropology in the department. And I was fortunate enough to work under him, and microdisc project was in, and in that concern, in that only we got a chance, an opportunity for an international training in public health in Brussels. And most importantly, what Mitra sir told yesterday, we also enjoyed a lavish dinner and lunch and breakfast during the microdisc meeting throughout. So thank you, sir, for all these things. I also want to greet all my teachers present here, respected teachers present here, who taught me during my graduation and the post-graduation times, my seniors and my loving juniors. So with due permission of the chair and the co-chair, I would like to begin my presentation. And can I share my screen now?
Yes, you can share.
Yes, you should be able to do that. You have the right. Yeah, it's visible, Meenakshi.
Yeah, at the very first place, I would like to delineate three important aspects, or to say the argument upon which my whole presentation, or to say that it has laid the foundation of my research paper. The very first thing is conceptualizing the term quality of life, how I have conceptualized or how it has been described or defined, the term quality of life. Second, what is the purpose of measuring quality of life in the post-disaster context? And third, and it's very important, the close association of the notion of vulnerability of women in the context of disaster. So against this backdrop, I would like to now share my findings and my views. So to begin with my first question, the concept of quality of life. It was first coined in the USA in the post-war period to describe the effect of possession of cars or other consumer goods like houses. And later on, it was broadened to encompass certain aspects like education, health, welfare, economic, and industrial growth. So we can see that health was secondary when the term quality of life was coined. Health came later on. At first, it was the consumer goods which defined what is quality of life actually is. But in socio-medical literature, quality of life have been equated with a variety of terms, including life satisfaction, self-esteem, well-being, happiness, health, and the value meaning of life. According to Janssen quality of life studies, quality of life may be defined as the subjective well-being. Quality of life reflects the difference, the gap between the hopes and expectation of the person and their present experience. Later on, the quality of life research unit of University of Toronto, they defined it as a degree to which a person enjoys the important possibilities of his or her life. And for this, the three major life domains were identified, that is being, becoming, and belonging. Further, the widely used quality of life definition is one provided by WHO, and they defined quality of life as individuals' perception of their position in life in the context of culture and value systems in which they live and in relation to their goals, expectations, standards, and concerns. But here I have used a shortened version, short form 12, SF12 questionnaire, which is the shortened version of SF36 medical outcome studies, because it has been widely used in the post-catastrophic situation. So I have used in this questionnaire, there has been two sections. One is of mental health and other is of physical health. So I have covered both. Coming to the second question, what is the purpose of measuring quality of life after disaster situation or any catastrophic situation? So quality of life measures have become a vital and often required part of health outcome appraisal. Measurement of quality of life, especially after disaster situation, provides a meaningful way to determine the impact of that catastrophic event on the individual's well-being, overall health, and health-related services. So understanding changes in quality of life after disaster may have important implications for managing health and health-related issues in other disaster-prone areas too. Now, the most important and the third point, the association of notion of vulnerability of women. So as we know that the status of women in India is a sort of a paradox. I would like to say, if on one hand, she has made great stride in many areas, and on the other hand, she has been silently suffering the violence. Inequalities persist in all spheres of her life, be it access of education, healthcare, physical and financial resources, or the opportunities in political, economic, social, and the cultural spheres. And these situations persist not only in the normal circumstances, but also during the adverse situation like disaster. And it has been observed that women's vulnerability has risen during any disaster situation or any such adversities. The issue of vulnerability, although this issue of vulnerability was not addressed earlier in the disaster studies, or maybe it is due to the tyranny of urgent, we have to deal with the health system, medical point of view. So this issue was not very much studied. But in the last 2-3 decades, it has been widely discussed in the disaster scholarship. And it has been found that why women are more vulnerable, and the certain commonly cited reason were economic marginalization of women, their unequal access to resources, women's responsibilities for domestic duties, which increases more during the difficult time of disaster, I must say, and women's role as a primary care provider for children, elderly, and sick. And this care provider duty increases during the time of disaster, or you can say in the post-disaster context also. And further, it is very important that women have specific reproductive health needs. And due to this specific reproductive health needs, they are more vulnerable during the adverse situation like disaster. And because of this, they also suffer. It has been observed that women also suffer from the gender-based violence in the post-disaster context. So with this background, against this background, I would like to now start sharing my findings. The present study, I have tried to locate women in the aftermath of devastating Kosi flood, which came in 2008, August 2008 in Bihar. And in this, I have tried to analyze the quality of life in terms of physical health functioning and mental health functioning. And for this, I have selected the study area was Basantpur block of Supaul district in Bihar. Supaul was one of the first districts to be affected from the Kosi flood. And for the study, I used cross-sectional survey with a total sample size of 250. 125 from the high flood affected areas, because it is sort of comparative study between affected and the unaffected areas. So 125 from the high flood affected areas was selected and the same from the unaffected one. Purposive sampling was used with those respondents who were willing to be the part of the study. Ever married, it's a all women study, and for this ever married women aged 70 to 49 were eligible for the study, and they were recruited after proper informed consent. And for the purpose of the study, I have used mixed method approach. Both quantitative as well as qualitative data was used. For the quantitative method, as I told, I used SF36, which is the shorter version of SF12, which is the shorter version of SF36. And in the qualitative methods, I have used FGDs, focus group discussion, case studies, and narratives. So SF12 consists of two components, mental health and physical health. And each mental health as well as physical health, further, they are divided, or they consist of 4 subscales. So the subscales of mental health summary are role, emotional functioning, mental health, vitality, and social functioning. And the subscales of physical health are physical functioning, role physical functioning, pain, and perceived general health. Coming to the findings, the affected group scores significantly lower on the physical health component as an indicator of functioning than the unaffected group, as well as in the mental health component also. You can see the difference in the mean and the standard deviation is there. The subscale of physical health summary revealed highly significant difference between the affected and the unaffected group. And similarly, the subscales of the mental health summary scale also revealed highly significant differences between the affected and the unaffected group. This is the table mentioning the mean, standard deviation, the t-value, and you can see the significant difference between the affected and the unaffected group. The p-value is mentioned here. Further, among the affected group, association of certain socioeconomic and demographic variables with that of the quality of life was calculated. After the calculation, a non-significant relation was found with that of age and quality of life among the respondents. Similar non-significant relation was found between respondents' employment status and perceived social support. Here, social support, I used social support only in context of neighbors' help, not going into the broader concept of social support, like inclusion of certain organization, NGOs, and other distant relatives, but just confined to the neighbor support. Whereas highly significant relation was found between quality of life and respondents' literacy status. And similarly, significant relation was found between quality of life score and the person who has taken loan, or you can say the financial burden upon the respondent. Among the affected and the unaffected group, a highly significant difference was found between the groups on both the subscales with the physical health summary score and mental health summary score. Many studies are conducted to assess the quality of life in the aftermath of disaster. And they have found the poor quality of life among the survivors due to many factors. But in this study, since I have compared the affected with that of the unaffected one, I can quote the similar studies by Khatri et al. In 2009 and Wind et al. In 2013. They also had tried to compare the quality of life among affected population with that of the unaffected group, and have found significant difference between the groups, same as the present study. And the findings are consistent with other studies which accounted that disaster had significant effect on psychological and physical health, especially in those instances where there is a significant loss of life, extensive property property damage, and severe economic disruption of people's life. Further, there was a non-significant relation found with age and quality of life, although this finding is not in congruence with other studies conducted with disaster. But because many studies has pointed out that the older people, they have poor quality of life, mainly, generally. But in my study, I couldn't find this type of correlation. But there is also a view that cross-cultural research suggested that the effect of age may differ across countries according to the social, political, economic, and historical context of the setting involved. So coming to my study, the study shows that around 83% of the respondents fall in the age range of 18 to 38, and only 17% in the age range of 39 to 48, with mean age of 30 years. So it may be possible that respondents' age being not falling in the category of much older one. So the perceived quality of life does not get affected with age. Now, coming to the second point, the highly significant association was found between the quality of life and respondent literacy status. Recently, scholars have pointed out that literacy has significant advantages in terms of subjective well-being, in addition to its well-known micro, macro, economic, and the social outcomes. The probable explanation for this association may lie in the fact that literate person has more personal control over their life, as they have more access to economic resources and support from the families. Several authors have also shown the importance that education has in increasing the sense of control over life, personal satisfaction, and access to a stable relationship, or in other words, increasing subjective well-being. Although this correlation between education and quality of life is not much studied, and I think it should be one of the area of research further. Similarly, financial crisis in form of loan burden was found to be highly significant with the quality of life status. The respondents from those families which have taken loan during last year in the aftermath of disaster had poor quality of life than those who have not taken. The stress caused by financial burden in form of loan was taking toll on respondents' health and health-related quality of life. Similar findings was reported in one study after Hurricane Katrina, where personal and financial losses were identified as the most common cause of post-disaster stress. And it was reported by 29.6% of the participants. In the study, the presence of stress in form of personal and financial loss was a factor associated with poor quality of life. So coming to the conclusion, I would like to say that stress caused by personal and financial losses in the aftermath of flood result in poor quality of life among the affected group. Additionally, literacy came handy as it provided with self-control and problem-solving skill at the time of disaster. The findings are important because it provides significant relation between that of the education and quality of life. Further, there is a need for detailed study in order to identify the mechanism by which education affects the psychological well-being. Economic needs in form of alternate employment options, restoring the social fabric by checking out migration, and adequate health and educational facilities, which were the main concern among the respondents. So following a major disaster, there is a need to specifically address the problems of women, empower them, provide adequate financial and social support, and enhance overall well-being. I would like to acknowledge Professor PC Joshi here for guiding me throughout the research work and bringing out this paper, my co-author Dr. Raul Kumar, and the organizing team for providing me the platform to share my viewpoints. Thank you. Have a safe, healthy, disaster and epidemic-free year ahead. Thank you. Thanks a lot.
Thank you, Meenakshi. Yeah.
I hope
So
I am on
it
time.
was, yes, you have exactly taken 19 minutes. So 1 minute is still late. But we will discuss later. As usual, your diff thinking and engagement is reflected in today's topic. So we'll take the discussion if there is any question from the participants.
Thank you.
So I would like to call upon the next presenter. Next presenter is Dr. M. Kennedy Singh. He would be speaking on the topic, a study on attitudes towards menstruation in Assam. Sir, over to you.
So thank you very much, and I would like to thank our department for organizing such a wonderful seminar and giving me the opportunity to speak about some of the topic which is less traveled by. And I also like to thank the chair and co-chair for being with us, and my co-presenter in the session, and all the viewers. So my topic, which I'm trying to discuss here, is a study on attitudes towards menstruation in Assam. In fact, this is in fact a taboo kind of the topic, which is been often silently discussed in the corner groups, but not in the public. However, it is so important that everyone know about the consequence of what it could be when there is certain kind of malfunctioning of the system, the bodily system, and the changes which has been occurring at the very prime stage of life. In fact, the paper tried to bring out the socio-cultural imperatives of the cultural values which is imbibed among the Hindu communities in Assam in particular, and the Hindu society in general. If you try to look back some of the studies, you'll find even among the Manipuris, among the Maites, we do have certain kind of practices which has been initiated at the onset of the puberty, which the parents ask, especially the Vaishnavite Hindus, the parents ask to visit the mandir and try to preach certain kind of rituals activities, the so-called the Laimung Lauma. So this is again a very important aspect, which is very very essential to study and to discuss in our contemporary society, because this is a kind of topic which is totally abandoned in some consequences, rather than taking up as a core aspect of our physical health. Perhaps it is not only the concern about the physical health, it is also something to do with the psychological health. So my paper, in fact, is developed with one of my PhD scholar, Angana. I'm very especially thankful to you for keeping track of this particular challenging topic, and this particular topic which we built up in this very particular short span of time, because she just recently joined in her PhD, and we try to build on, and as a part of the PhD work, we try to extend this particular topic, and from there we try to churn out certain kind of informations, and this is how we built on this particular paper. So in this particular paper, we also try to look at how the very particular ritual festivals, which has been associated with the puberty among the Assamese in Darang district in Assam, which is a very sacred places, and Assam being a place which is religiously very important, being the presence of Kamakhya Mandir. And we also have a lot of importance on how the empowerment of women is related with the kind of mythology which is associated with the Kamakhya Mandir and the religious significance to the society on how it molded the personality of an individual in the society as well. So this particular paper tried to bring out the socially stigmatized topic, but equally important for the better society. The so-called Toloni Bia, which has been practiced among the Assamese in Assam. And this particular topic, when we try to discuss about, we need to know the meaning of what the menstrual cycle is all about. And is it a natural phenomenon? Whether it has been associated with the cultural interpretation of it, and whether it has something to do with the mythology of the reason. So the paper attempts to study how Assamese culture and its perspective that affect on the process of this particular menstruation process and the menstruation hygiene. We call it, in the world of science, the personal hygiene. So it also tried to bring out the personal experience of some of the people whom we engage with through their narratives. So this is a very interesting area which we try to travel with some of the anthropological tools and techniques for the collection of the informations, the so-called data, like the personal interviews, the ethnography of my co-author itself, on how the personal hygiene and management among the adolescents, girls and women. So we also try to bring out a lot of data relating to this particular practices, especially by engaging them through certain kind of in-depth interview, and also being part of the rituals. So this makes us certain kind of ground realities to clarify some of the doubts on how important this particular bodily process in the context of the Assamese society. So the paper tried to bring out certain kind of understanding on how Assamese culture influence the so-called the personal hygiene among the young adolescent girls in particular, and how they encounter and how they cope up this kind of panic situation when they first encounter in their life. So if you try to bring out this kind of traditional practices, we can look at both the negative as well as the positive side of the coins. So if you try to bring Toloni via this particular ritual festival, which has been a kind of medium to introduce to the young girls about what is we call the menstrual hygiene. What is we call the menstruations, a bodily change, the process of change. And it also try to highlight about the negative effects with the concept so-called Choa among the Assamese local language, means pure, impure, the concept of pure, impure. And also with the concept of Subida in local terms, means the difficulty which they encounter during this period. So this is something to do with the kind of, the kind of influence by the peer groups, especially the opposite genders, which they try to, highlight in the form of embarrassment, shame, and low esteem, which sometimes they affect about the schools and their schooling. So when we try to discuss about this particular ritual phenomena, it is something to do with how the community, especially the mother, taught the daughters about the well-being, about the personal hygiene, about the conduct of life, about the rules and regulation of being a good. So it has something to do with the ritual birth. It has something to do with the isolation of the girl itself. It has something to do with to touch and not to touch. Now the question is, how does this very particular concept of to touch and not to touch comes in? And how this particular, concept of touch and not to touch, the concept of impure, influence the psychological health among the young girls. More importantly, we also try to talk about the kind of, ritual which has been associated with the community. And, if you try to look at these particular rituals as a part of the life-changing movement, now, questions come to our mind: how much it influenced to the individuals, how much it influenced to the girl by a mother, whether it has a positive side to do with, but at the same time, how much these particular rituals reflects the positivity of the personal hygiene, rather than merely or symbolically, practicing as a, as a fish or a ritual among the family members or among the community. So in general, the puberty rituals continue for a long time, including 3 days of the confinement period. So one of the key features of this ritual is the girl introduction to the menstrual health, and the rituals begin with the first day of the menstruation, and it continues for 7 days. So what I feel, very interesting about this particular rituals is, it's a one way which we can socially learn, which we can socially, introduce the practice of personal hygiene, if not in a very in-depth way. But I think now, because of lot of influence from the modern educations, media, movie, social network, that brings a lot of changes in the society as well. So Now, in this particular community, it is very interestingly to say that a girl is not permitted to see the sun or the moon or any other male members of the family, including her father. So it is often associated with a girl that is married to a banyan tree, to a banana tree. But in the community like the Meiteis in Manipur, it's been often married with papaya tree. It's often married with the tulsi, with certain kind of ritual practices by the elderly man of family, or sometimes it is been introduced with the local Brahmins, which they whisper certain kind of religiously valued mantras, and they were asked not to tell anyone. This is how, when I interview some of the communities in my place, it is very interesting, and why they are not asked to tell to other. This is also one interesting aspect that we need to look into. So what we have understood from this ritual is that it is a traditional way of informing a girl about her menstrual health, and they're expected to follow all the rules and regulations. And it is also the first time which the mother will be introducing certain kind of the topic which may not be familiar before. And the introduction of definite set of rules. So when you talk about the menstrual hygiene management among the young girls, this hygiene can be achieved through the use of different mechanisms, either sanitary pay, washing, or disposal mechanisms. But at the same time, the affordability and the acceptability of this particular mechanisms is also a great concern, because if you try to look at in the rural areas, most of this, whatever we have mentioned here, may not be discussed openly, and whatever the personal hygiene products may not be equally available. If it is available, it may not be quite affordable, and they are confined to engage themselves with those traditional way of coping up, either with the advice of their mother, with the advice of their sister, by using certain kind of clothes which is available in the home. And convenience could be a different problem which it comes up in the context of their personal hygiene. So this is something to do with the interventions at the policy level, because we all know that we have old sisters and daughters who are going to the school. If we introduce this particular topic to them beforehand, then they will be very panicked when it comes up. So it is very important to understand the psychology of the young girls. It is very important to introduce this very topic in a very comfortable way, and we have to make them comfortable. We have to make them to bring out the ideas on how they can handle So it is all depends on the personal involvement, especially at the family level. So in this particular study, we bring out the initiative of the mother, we bring out the initiative of the siblings, especially their sisters, especially we talk about the initiative of their aunties, has something to do with this personal hygiene and the well-being of the human health. So we can say, in other words, that menstruation is not just a bodily phenomenon, but it's also a psychological thing. So we're very thankful to the new initiatives, especially the education system, which it brings out the awareness, especially in the schools, which it brings out the knowledge about their bodily transformations. So in this particular paper, we try to make an attempt on how we can communicate the very, concept of impure into a very understandable way, not at the level of the cultural impurity, but could be in the context of, well-being of the female health. So I would, rather bring out a message by saying that let us empower and support our daughters and sisters to bring a healthy society. This is the message from the learning from this study. Thank you very much. I think I'm in time.
Yes, sir. You're exactly in time. Yeah, you have taken 20 minutes exactly. Thank you so much. You have covered an interesting topic. I would say a very silent practice, but which is really salient to all individual members. I would say to all human beings. And also, I would like to congratulate you for taking the courage of presenting such a topic, because what I generally come across is that I'm not trying to make a gender comment on it, but usually there is a reluctance of giving a presentation on menstruation or women's health by menfolk in general. I may be wrong, but this is my own perception. So I really want to congratulate you for taking up this topic. Thank you, sir.
Okay. On a lighter note, actually, I would like to, I would like to ask my student to present it, but then on the same time, I'm compelled to do it.
I think you have done the right job, actually. Yeah. So it's a new beginning, I would say. Thank you, sir. So I would like to call upon our last speaker of today's session, Dr. Kalindi Sarma. She is going to speak on the topic, a discourse on gender, health, and sustainable development in India, and eco-feminist thought. Kalindi?
Yes.
Okay. Yeah, over to you.
Hemlata ma'am, am I audible?
Yes, you are audible.
Okay. Thank you so much. So in the very beginning, I would like to express my gratitude to all the organizers who have organized a very interactive event in the honor of Professor Joshi. I would also like to express my gratitude to Professor Joshi for always guiding us. And academically, he is somebody who's responsible for teaching me academic rigor, methodological rigor, how to use combination of methodologies in fieldwork, and I have actually under him gained a lot of field exposure using various kinds of methodologies and novel methodologies like visual anthropology, and how to include it in my research. So these are some of the things that I have learned, and I hope that Sir continues to guide all of us. Even now, given his busy schedule. So my paper is a discourse on gender, health, and sustainable development in India and ecofeminist thought. And this paper in many ways is quite different from rest of the papers because it is a review that I've written on ecofeminism and sustainable development. And it primarily focuses on a critique of ecofeminism and sustainable development as theoretical models that have guided climate change narratives over years. And moreover, I have tried to include a small portion on health because my primary research has never been on health. So I'm apologetic at the very beginning if there is any mistake on my part, correct me if I'm wrong. So I shall be reading some significant excerpts from my paper. So within the discourse of environmental management, women have been considered synonymous to environment. Images of women sharing an enduring sorority with nature, nature's maternal, or earth being considered as mother are common in relation to the debate on sustainable development. Alternatively, the destruction of biodiversity for capitalist ventures has been termed as a patriarchal pursuit. As a result, while development leading to homogeneous cultures became a masculinist endeavor, women have been recognized as repository of indigenous knowledge, especially with regard to conservation practices, awareness about local flora and fauna, sustainable lifestyle, and so on. This recognition led to the inclusion of women's perspective in environmental advocacy and policy initiatives around the 1980s, followed by the establishment of special panels on gender in global environmental forums. Subsequently, the link between gender, health, and sustainable development also assumed significance, and it requires to be explored further in detail. Now, my paper critically examines paradigms of ecofeminism, through paradigms of ecofeminism, locations of gender vis-a-vis sustainable development with brief focus on health and well-being of women in India. The unbridled development around the globe has raised several questions on the voracious appetite of human beings, especially with regard to depleting natural resources. For scholars of gender and feminist studies, this unconstrained ability of development to plunder and ravage biodiversity bears an uncanny resemblance with the oppression of women and other marginalized categories. The parallels between the vulnerability of women and the susceptibility of the environment to unmindful exploitation emphasize on the inherent power dynamics within the climate change and environmental politics in general. The sustainable model of development seemed like a providential response that could reverse the massive anthropogenic exploitation by restoring the balance between human beings and natural resources. Sustainable development was brought into mainstream policy-making commissions with the view of preserving the leftover resources and also instilling in people a mindfulness with regard to the utilization of whatever was left on the planet. The entire idea of sustainability was therefore focused on resourcism and preservationism, and these two ideologies have been critiqued by scholars for being more anthropocentric rather than being planet-centric, because they only talk about the consumption of resources by the people who exist today, or the people who have in many ways been considered responsible for resource exploitation. Now, when we go to women and their contribution, the earliest reference is of Chipko movement that was organized in 1970s in Uttarakhand. And during this movement, the role of women was something which was internationally, which gained international recognition and global recognition. And when this happened, there was a conference in Nairobi on women, and Chipko movement was raised as an example that introduced a shift towards inclusion of gender in policy planning in order to protect the environment. This was in 1985, and after around 7 years, when the Earth Summit took place in Rio de Janeiro, the voices of women from the global south became more palpable, and their vulnerability to sudden catastrophic events as well as long-standing environmental degradation was acknowledged by the stakeholders. At this time, a number of ecofeminist voices had found representation at the United Nations Conference on Environment and Development. It seemed like the daily realities of women and their secondary position vis-a-vis men resonated on the forums for environmental management. However, there were several arguments by feminist scholars that pointed out the inherent contradiction in belief wherein women faced a sort of quandary of being a disproportionate victim of natural resource depletion while being a repository of knowledge about its preservation and protection. The scholars also warn of the risks of positioning women in environmental projects and programs that sidestep existing disproportionate workload and gendered hierarchies. In short, the slogans that drew attention to women as the environment's victims and caretakers did not match the more complex and daily realities of resource use, power, and negotiation. Such manifestation of women's predicament as the sole bearer of knowledge and the simultaneous position of marginality raises concerns about their inclusion in policy framing regarding environmental conservation. Now, when we come to the ideology of ecofeminism, I would like to focus on the work of Vandana Shiva, who's a scholar who has focused immensely on ecofeminism, and also Maria Mais, who has collaborated with Vandana Shiva quite a number of times, and also Beena Agrawal. So these are some of the stalwarts that have focused on ecofeminism in India. The integration of the lived experiences of women and the widespread destruction of natural flora and fauna of the planet was not merely a metaphor for the sake of ecofeminism. Instead, the movement intended to convey how the entire human race was so deeply entrenched with the environment that any detrimental impact on the environment would eventually lead to adversity for the entire human race. It was in 1974 when a French feminist, Françoise de Bon, introduced the term ecofeminism, and it was considered a hallmark for the third wave of feminism, which was more action-oriented and focused on intersectionality of feminist movement. The ecofeminist theoretical paradigm has primarily been supported by three models, which is empirical, conceptual, and epistemological. Now, Vandana Shiva is somebody who has focused on epistemological model, but I will briefly mention that the conceptual model is a cultural symbolic idea that promotes maternal imagery of woman who's fertile, capable of bearing children, feminine, and supports and nurtures life. On the other hand, the empirical model is more of a statistical account of how more women are affected by climate change phenomena and disasters compared to men. And then finally, the epistemological structure of ecofeminism focuses on women having epistemological superiority over men because their own experiences of oppression and struggle makes them better equipped to understand resource depletion and advocate for its conservation, because there is a constant parallel between how the nature is being treated and how they are being oppressed at the hands of men. Examples of women as the nurturer and caregiver were used far too often by environmental policy stakeholders, because most of the examples that were cited at international forums came from rural and tribal regions of South Asia, where women were responsible for reproductive labor and would procure, the rural and the tribal women would procure most of their resources from the forest and were dependent on forest produce for their sustenance. So Vandana Shiva, who has championed the epistemological paradigm, posited that patriarchy was not only responsible for subjugation of women, it also worked towards destruction of diversity of nature, as it was a major roadblock in the vision of developmental expansion. Time and again, Shiva has been known to support the claim that destruction of diversity and creation of monocultures becomes an imperative of capitalist patriarchy. Women are keepers of biodiversity, according to Shiva. The recent concern with biodiversity at the global level has grown as a result of erosion of diversity due to expansion of large-scale monoculture-based agriculture, which in many ways discourages sustainable practices. It is important to remember that feminization of nature doesn't naturally or biologically endow women with the responsibility of preserving nature, it is just across. If we look at cross-cultural examples, we will be able to perceive diversity in the lived experiences of women vis-a-vis nature. The tendency of ecofeminists is to create a monolith of women. So when they talk about women, they don't necessarily address the intersectionality or the margins within the margins narrative of women. And as a result of that, what happens is that they have a tendency of creating a monolith for which they are critiqued immensely. Environmental scholars from Asia believe that the maternal image of nature is something which is a Western thought, and it is a Western perspective that has dominated us in the global South for a long time. For instance, when we talk about some examples from South Asian cultures or Southeast Asian cultures, there's an example that has been given by scholars that Chinese don't necessarily identify Earth as mother. But when it comes to exploitation of nature, the rape of the Mother Earth is a common metaphor that they refer to and that they commonly accept. And it is for this reason that the colonization, the world that has been colonized is still being considered under the influence of these Western narratives, because it is very biblical to consider nature as mother in many ways, although we also have some Vedic references that support it, but they have not always been invoked in order to support this ideology. So both Maria Mais and Vandana Shiva believe that for many tribal and peasant communities in developing countries like India, dependence on biodiversity for subsistence is a common phenomenon. Their methods of sustenance are often considered primitive and backward. These are derogatory terms, of course, but the regional governments are quick to change their slow-paced lifestyle into something which is more new age technology oriented, and statistically it is more yielding, and therefore in the name of modernization, in the name of development, many a times the sustainable practices take a back seat. The capitalist patriarchy is only motivated by higher yield, and this is a statement again by Shiva, and output by minimizing cost of production as opposed to a more balanced and simple livelihood strategies of rural and indigenous communities of South Asia. When we talk about the subsistence perspective of Vandana Shiva and Maria Mais, again, we talk about how it may be considered idyllic and Arcadian because it does not sometimes seem very feasible and a very acceptable idea in contemporary times. The reason for that is that the critics of Shiva have accused her of romanticizing with the poor rural Indian woman who supposedly did not witness any history of oppression or exploitation in times preceding colonization and technological expansion. So it is a kind of a disconnect that Shiva has not been able to really address. Several critics of ecofeminism have argued that with the introduction of technology, there have been cases of women living in delicate biodiversity being able to overcome, challenging biodiversity, being able to overcome their physical drudgery because of the technology. So this whole idea, the proclivity of ecofeminists to condemn all things Western and to condemn all things development-oriented is something which holds little significance. There are critics who do not overlook the efforts of Maria Mais and Shiva in bringing to light the subjugated knowledges of oppressed people and the need for integrating knowledge to more culturally plural, in a more culturally pluralistic manner. Meena Agrawal is another ecofeminist who has a slightly different view of ecofeminism, and she has popularized what is known as feminist environmentalism as a form of ecofeminist thought, which does not overlook the aspect of intersectionality, like the intersecting elements of caste, class, religion, and power that women share with nature. As a matter of fact, Veena Agrawal is known to affirm that seemingly eternal bond which women share with nature is eternally influenced by their caste, class, and access to resources, healthcare services, and not just their gender alone. For instance, a woman in urban India is less likely to be in tune with nature when compared to her rural or tribal counterpart because her survival is not entirely dependent on forest produce. And therefore, it is important for us to address intersectionality within the purview of ecofeminist thought because it is the onus of the researchers to address these issues of intersectionality, as there are numerous social constructs that define the relationship human beings have with their natural surroundings. Now we move on to the whole idea of sustainable development. So in 1971, 87, the Brundtland Commission published a report which is commonly referred to as Our Common Future, that describes sustainable development as development that meets the need of the present without compromising the ability of future generation to meet their own needs. Now, the report did not intend to impose any strict sanctions or limits on the use of resources by various countries, but it did highlight certain issues which were important for the world to address. In the report, the Commission elaborated upon the delicate balance between economic growth, population expansion, and resource exploitation, and it outlined a course of planned exploitation of ecology wherein there would be a scope for expansion of natural resources elsewhere. Each point in the course of action charted out by the Commission bears awareness about the exhaustion of naturally occurring resources if the pace of utilization is not curbed. At the same time, the report relays the entire future of the planet in the hands of those stakeholders who are the participants of the said exploitative order. While it is reasonable to entrust the stakeholders with the responsibility of preserving and replenishing the natural resource base, it is only feasible when the stakeholders realize the importance of the objectives defined by the Brundtland Commission. The concept of environmental sustainability was always narrowed down by its ability to cater to human needs. Again, it is something which is an idea that is considered more anthropocentric. Human needs have proliferated at an alarming rate, and it has become a major challenge to provide for the ever-increasing world population. Sharp decline in the natural resource base is a reality that man had to witness sooner or later. There have been other struggles of the socio-political order that the environmental community has had to face since the culmination of the Environmental Task Force in the 1992 Rio Summit. It is this strategic and planned exploitation of resources that ecofeminists have vehemently opposed to, and as it would lead to further marginalization of the vulnerable population of the region. Moreover, the destruction of the habitat for non-human species is a major concern as it would inevitably change the face of the planet. To an ecofeminist scholar, this ideology of sustainable development is characterized, as I said earlier, by anthropocentrism and the self-serving ideals of humanity. One of the major drawbacks in the way sustainable development was viewed in the 20th century was its limited focus on socio-political dimensions of the society. The focal point of sustainable development was restricted to environmental and economic dimension. The pioneers of our common future discussed about the importance of an alliance between socio-political, economic, as well as environmental domains, but it failed to impress upon the inclusion of socio-political domain of the society as a means to facilitating sustainability through the establishment of robust governance in nation and states. Needless to say, the model has been selectively successful in fulfilling the Millennium Development Goal and the subsequent SDGs, which I would be discussing later. The framework of sustainability in Global South is something that we need to discuss now, because the Global South and the Northern Hemisphere have always been divided. The Northern Hemisphere has been responsible for more or less colonizing whole of the Global South, and therefore they have been held accountable for rampant consumption of natural resources. With the introduction of sustainable development and global environmental concerns, the Western world has recognized the need for development for third world countries and have granted them, in a way, it seems like they have granted them the opportunity to utilize their resources with a long-term vision to provide for subsequent generations. There's paucity of time, otherwise I would have given several such examples where most of the production of the resources and most of the resources are here, and most of the production that takes place for the Northern Hemisphere is in the Global South, and how most of the sustainable development goals have been refuted time and again in the name of providing for these people in the Northern Hemisphere. The countries, the sustainable development approach is meant to challenge the conventional paradigms of development by imposing sanctions regarding resource use and by introducing strict protocols for biodiversity conservation. The conventional and dominant framework of development that Vandana Shiva termed as maldevelopment favors rapid industrial expansion and global trade agreements between the Northern Hemisphere and the global South. This model of development opposes the subsistence economy of the third world countries that is both capable of fulfilling basic human needs and least exploitation of natural resources. However, the subsistence structures of economy are proclaimed as penurious and incapable of establishing trade agreements on an international forum, for they are not inclined to exchange commodities and earn profit if countries of the global South in any way try to ratify two sustainable development goals wholeheartedly. Therefore, developing nations that are driven by subsistence economy, when faced with an environmental catastrophe or any other trauma, rarely find themselves being granted aid by international trade forums. In the light of this fact, the notion of sustainability has failed to lure developing nations into a more far-sighted and visionary approach to development. Furthermore, from a philosophical point of view, the idea of sustainable development has been marred with ambivalence, much like the ecofeminist thought. Quite like an oxymoron in figure of speech, the concept of sustainable development relies on terms sustainable and development that are more or less oxymoronic in nature when we talk about the ideology of sustainability and development. The two terms claim extremely separate positions from a philosophical perspective. Yes.
May I interrupt? Can you try to finish? There are
Yes,
also questions available and a shortest of time.
Absolutely.
Yeah.
So I'll directly now go to the concluding remarks. This paper has attempted to outline how sustainable development presents a quandary for most environmental scholars, social scientists, and economists, as it compels them to choose between health and well-being of humanity or the health and well-being of the planet. The task of bridging the gap between the two has been nothing less than a challenge and has ended up being a pursuit for unattainable balance. Despite the numerous controversial debates and discourses on the concept of sustainable development and sustainable development goals per se as the most effective methodological tool, it still remains the most refined and significant step towards environmental protection. Moreover, the allocation of the entire gamut of environmental concerns under an umbrella of sustainable development has led to widespread attention on the issue of natural resource depletion. So we cannot outrightly refute the whole idea of sustainable development. The discourse on this sustainable development has also reinforced the dominance of the Western world in a manner where Western powers are using it to define the course of resource utilization for developing nations. This creates a counter-consciousness whereby the first world, with all its economic and trade negotiations in the third world, feels obligated to champion the environmental goals of sustainable development that they have inspired and insisted upon. This paper also explores how ecofeminism studies women in relation to their ecological surrounding and comes to exclude the men who bear an irrefutable stake in environmental concerns in trying to negotiate the exclusion of oppressed and vulnerable voices at large. The narratives of sustainable development as well as those of ecofeminism both have proclaimed vulnerability of women and nature as natural corollaries and symbols. The subsequent narrative is thereby of repudiation of technological advancement and other parameters of industrial capitalism. It is often forgotten that dynamism of industrial progress at times alleviates the marginal position of women amongst many others in terms of labor, health, and education. So this paper actually probes into many of these contradictions and explores through its critical inquiry the monoliths of sustainable development and the fables of ecofeminism that perennially negotiate the space of women at the face of changing patterns of development in India and also the rest of the global South. So that's it from my side. Thank you so much. Thank you to the chair and co-chair as well as to the moderator.
Thank you, Dr. Kalindi. It's a really nice presentation. My heartiest congratulations.
Thank you.
It's a great presentation. You have actually given a detailed account of understanding gender, health, and sustainable development using feminist, particularly eco-feminist, thinkings and ideas, bringing Vandana Shiva's and others' viewpoints, and also critiquing. So as we do not have much time, I think we have only 10 minutes left, and we have also got questions in the chat box. I would like to now take up the questions starting from our first presentation. We've started. Okay. So I would like to read out the messages which are given. The first one is coming from Aruf R. Bandapudhaya. Nice area chosen, Professor Saraswati ma'am. I think this is about ma'am's presentation where he says that this is really a changing idea and effects of micronutrient like folic acid. Maybe genetic counseling prior to pregnancy is important in this area, such as maternal alpha fetoprotein level estimation is indicator of discontinuous multifactorial entities. And then another comment for Saraswati ma'am from Avisek Vomik, that is considering the fact, I think this is a question to ma'am, considering the fact of overdoses of folate, how is it most likely to cause an epigenetic change which might result into cancer? Would the overdoses interfere with the normal pathway of the folic acid, which has end products important for DNA mechanism, or the amount of overdoses might deposit to turn out to be toxin, which can develop to other complex disorders or to turn out to be possible carcinogens. So I think I will stop here so that ma'am could give a reply on all these queries first. Ma'am.
I was not very clear. Actually, I could not hear the whole thing, what you read.
Yes, yes. Actually, there are long set of questions. But
I think just a minute, Lata. I think ma'am can read the question on her own. Can she?
Which one?
Can you go to the chat box, ma'am?
I'm in chat box only.
Yes, and
if you question from Abhishek Bhomik, and the question is regarding like
the three symbolism of identity, epistemology, empirical. What is this?
No.
It's not my question.
No.
It's at 11:26. I'll just read out the question, Dr. Saraswati. If like considering the fact of overdose of folate, how is it most likely to cause an epigenetic change which might result into cancer? So as you spoke about the intake of folic acid and cancer, so what is how is it related, the epigenetic change? Would the overdose interfere with the normal pathway of folic acid, which has end product important for DNA mechanism, or the amount of overdose might deposit to turn out to be toxin which can develop to other complex? This is the question from Avishek.
Yes. Very nice question. First of all, let me start with the first part of the question is whether overdose of just 1 second, Rumi. Somebody is talking in my house. I'll ask them not to talk. So actually, the relation between high folate and cancer, actually it is not completely established. Mechanism is not yet found, but still people are reporting that high folate means more high methylation, hypermethylation of certain genes. When we talk of hypermethylation of certain genes, that means less expression of those genes. And if these DNA repair genes or tumor suppressor genes, if they are hypermethylated, their expression will be so less that they will not be able to stop the tumorigenesis. So that could be one of the reasons how folate can be associated with cancers. It is just an assumption. It is not completely established. And what was the second part of it? Overdose. Yes, overdose of folic acid leads to folate trap. There is another concept called as folate trap, and in which what happens is, and especially in those individuals where there is vitamin B12 deficiency, that is specifically in Indian context where B12 deficiency is high, and if you have more folate, that will mask the effect of B12 deficiency. We will not be able to identify B12 deficiency, and giving folate to those people will be more of a problem in terms of neurological problems. They may develop certain So most of the time what happens is whenever a person is suffering from some neurological disorders, they also try to correct it through micronutrient deficiencies. There, if you give folic acid thinking that it will correct it, it will aggravate the problem. So these are the issues for high folate. For that matter, in any pathway, everywhere where micronutrients are performing, any supplementation in artificial form is not good unless they are found to be deficient. If they are not deficient, you're not supposed to take vitamin tablets. You should not take just like that. Iron tablets, there are countries which have banned iron supplementation. So this is what my submission in my talk. Yes, I think I have answered the question. I don't know. Abhishek,
I think you have covered, ma'am, because the last question is more or less similar. It's also about the overdoses of that folic acid, and then, you know, whether this toxin has also related to other disorders while, you know, in the process of leading to cancer. Is there also other abnormal situations and all? That's the question.
Definitely, including even, you know, there is one mouse model study, you know, in vitro study, like they were, and high doses they gave to rats, and they found they had a lot of pregnancy complications, abnormal fetuses and abnormal childbirths in animal models. We are not able to prove that in humans, because we don't find people with folate deficiency during pregnancy. Everybody is folate replete.
Right. So thank you, ma'am. And there are also people who have given appreciation to your presentation. There are lots of these in the chat box. So I would just come to the next question. And this is for Dr. Bipin Gupta. Bipin, I don't know, have you gone through the chat box? There is a question. If you can go to the question directly, or should I read out?
I think there is no question in the chat box.
Okay, okay. So I think there is a question which is not clear, but I'll just read out. It came at 11:38. Okay, and this question came from Abhishek Vome, saying that first is the appreciation to you, and the question is that biologically we have gender balance. Suppose there is a need, it is the social gender balance. So it's a little bit vague the way question has been raised, but if you can connect it. The question came at 11:38 a.m. Yeah.
I think, yes, it is. Yeah. Biologically, both males and females are very much balanced in terms of hormonal balance, in terms of strength, endurance in both the sexes. They're very much balanced because males have some strength, females also have some strength. Males have some limitations, and you will find, females also have some limitations biologically. But it is all about, if you look at the inequality in terms of distribution of health resources, accessibility to the health services, or in terms of nourishing the child, maternal diet, all those factors, social factors related to the maternal and child health, they are basically embedded in the gender inequality because of social understanding of the gender inequality rather than biological connotation of it. That's my response.
Yes, I think the person has also commented again in the chat box saying that it was a comment. So I was a little bit doubtful on the way it's been written. Anyways, the next question is, I think, for Dr. Kennedy, sir. Sir, if you can go to the chat box, which is coming at around 12:40, at 12:45 p.m. The question says that, how can the three symbolism of the identity of any woman? No, this is, I think, for Kalindi, right?
Dr. Kalindi.
Yeah, this is for Kalindi.
Yes, ma'am.
So Kalindi, this is for you. How can the three symbolism of the identity of any woman, epistemological, empirical, and the other, I think, conceptual, be the basis of the conservation of biodiversity?
Thank you for the question, Mr. Bhomik. So there are three ideologies that guide ecofeminism. The conceptual model looks at the maternal image of women and draws a parallel between the women and nature. The next is empirical, which is a clear statistical quantification of data that more women have suffered at the hands of catastrophe compared to men. And the third is obviously the epistemological idea or the narrative that has guided ecofeminism, in which we talk about how women must not be looked at as hapless and helpless victims of catastrophe, but they should also be considered as repositories of knowledge, as banks of knowledge, indigenous knowledge and local knowledge about biodiversity conservation. Now, when you look at women as repository of knowledge, you are going to include them at various levels of policy and planning, which will have an impact not only on the conservation of nature, but also on the position of women in general, because they are not mute victims anymore. Rather, they are being asked to participate in what is going to directly affect them. So it is these three ideologies. So one, all these three perspectives in some way or the other have guided the perception of ecofeminist view. I hope my answer is clear.
Yes, I think. So thank you, Dr. Kalindi. And we have, I think, exactly 1 tree. But I think, you know, in the beginning of the session, sorry to say, but it's also an effort which I'm trying to follow what Joshi sir usually do in handling the session. Sir usually begins in time and then try to manage everything, you know, on that allocated time period, which I think we have also managed it. But now I would request Professor Romi Dev to provide her expert opinions and comment or appreciation on the presentations of today's session.
Thank you, Dr.
Over to you, ma'am.
And more than comments, I have full of appreciation for all the speakers today. Each and every presentation was an insightful presentation, and it has really enhanced our knowledge in various ways, right from the very beginning when Dr. Saraswati spoke about the importance of folic acid and other things in public health aspect, which is actually a very important parameter for the newborns and for maternal and child health. And it's a new insight which she gave, like folic acid, overdose of folic acid can lead to other health illnesses, including cancer in the later life of a woman, and where how B12 should be rather is important. And B12 deficiency again causes various health issues for women. So this type of things, like, which is very known, and I think it's very, very important, like we should research on and pass on to the health planners and the policy planners to come up with policy planning, which is very important. And now, and is the need, or need, maybe it's the need, it's also actually a need. So we should, as researchers should focus on this. So I appreciate her presentation, and it was a great learning personally, and I hope all the all participants present here have learned a lot from her presentation. Coming over to Dr. Vipin Gupta, it's again a very amazing presentation where he spoke about the social factors affecting the maternal and child health, and where he gave a very good insight about the socioeconomic and the gender class related to the women and child health, because it's very, very important, you know, like education plays a very important role. Then early age at pregnancy, where like you are not you are in the lower socioeconomic status and you do not get proper nutrition, health services, and health seeking behavior is not known much, so how it impacts the pregnancy outcome. So he has given a very extensive and a very good understanding about this. And he also spoke about immunization of the children. It's a fact, like I have seen in the field, like where when women are not aware of immunization, they have certain stigma and myth associated with it also. Like giving one vaccination, and if the child is unwell after the vaccination, they feel that why should we go for the second vaccination when our child is suffering from fever and so on. So it's the need of the hour to sensitize the population and bring awareness in the community, especially the rural community of our country, where they should take proper care of maternal and child health. for the better, so see, maternal health is important because of the better pregnancy outcome. And I suppose it was a good understanding to all of us because he spoke in a very lucid manner, which was very impactful. I come to Dr. Meenakshi, where she spoke on the cozy women and in the flood affected areas. So how the quality of life is affected after any disaster. So that again is a very meaningful and important new insight to most of us, at least me. So how individual well-being and is important, and how women face a different type of disaster or discrimination also in adversities like disasters. So this is a very important gender inequality, which I could see in the study, like even in the disastrous, in such disastrous situation like women are having, I think if I understood correctly, so women have specific a lot of health needs, so they may suffer from all the post disaster syndromes and symptoms. But there again, like, so women's quality of life needs to be enhanced, and significantly in the in context to mental health, and where the literate person, and she also mentioned about the literacy status and the financial and personal thing is important for the health of women. Then a very interesting study comes from Dr. Kennedy, which he spoke about the menstruations and the rituals and beliefs of menstruation in Assam, where he referred to Tulonibia. Yeah, Tulonibia means maybe it is the ritual associated when the child gets her first menstruation, and the difficulties faced by the women and girls in that community and in that environment, and how the mothers and daughters teach their children about the health and well-being, and what are the various rituals associated, and so all this there. And bringing to this, the improvement is there because nowadays education is helping to bring a change, and so there is a change in the outlook of in this particular area of our country in Northeast India. And then we come to Dr. Kalindi Sharma's presentation, where I think it's a very, very new topic for me. And she spoke extremely well, giving various case studies, and spoke about Vandana Shiva and Mariam, ecofeminist, as and their feministic, I don't know, epistemology, and that occasion. It means it's a new knowing for me actually. How she explained Dr. Shiva's feminine principle of nature and the awareness of nature as a living independent force, which I understood it's like is realized through the inclusion of women as a source of expertise and knowledge. And Shiva also said that she spoke about the epistemology that privileges the paradox of unity through diversity and difference as a solution to society's current ecological crisis. So I think Dr. Kalindi has spoken very well, and it has a very good understanding. And if I want to understand more, I can also personally talk to her and get more of understanding regarding this subject. It's a very interesting subject. Kalindi, you should also work on this area because you have such a good insightful understanding of the subject. With this, I should congratulate each and every speaker today who has spoken so well and who has given us so much information in various aspects. And thankful to my co-chair, Dr. Hemlata, and the moderator of today's session, Kiran Bala. So I'm thankful to you and all the organizing members of this national seminar for inviting me and giving me this opportunity to listen to such beautiful talks. And with this, I think my comments are over. Dr. Hemlata, it's over to you.
Thank you, ma'am, for your valuable
Thank you,
comments
ma'am.
and appreciation. I think as we have already taken time over the allocated one, so I would now like to give my first, last appreciation to the department and organizing committee for giving me the opportunity of co-chairing the session along with Professor Romi Dev, ma'am. And so I think I would like to handle the session to the session moderator, Dr. Kiran Mela. Kiran Mela, over to you.
Thank you, Rumi ma'am and Dr. Hemlata. It was a very interactive session. And Hemlata, if you want to summarize the session, you can summarize in a few seconds or few minutes.
Yeah, so I was just wondering, because when I see the topic and particularly the broad title of the session and all, it was very, intriguing to me that what are the points it should be coming up in the overall presentation and all. And the moment I listen Saraswati ma'am's presentation, it was just major learning process to me. And also it's so meaningful that everyone, not only the woman folk, but everyone in this virtual platform should think through to avoid the probable side effects while taking this medicine. And I'm sure that in India we don't have much knowledge about it, so ma'am has actually enlightened us a lot in this field. And the second presentation, second presentation given by Dr. Bipin. As usual, as I know Bipin Gupta very well, the way he engages with the topic itself, I was also thinking that what kinds of the study, which Bipin is going to talk about on today's presentation, when I see the title, the first word, social epidemiology, and also maternal and child health conditions. And then surprisingly, he has tried to cover up all accounts of social epidemiological parameters. And this is an area where I'm also trying to work on recently. So I think it's a kind of great learning where I could also get many things which I did not even think through while dealing on some of the aspects on social and epidemiological aspects of maternal and child health. So I really appreciate, and also a learning experience for me, Dr. Bipin, through your presentation. And next presentation is Meenakshi, right? So Meenakshi, as usual, I know that when we talk about quality of life, the concept or even the understanding of quality of life itself is always debatable and difficult to even qualitatively and quantitatively. And also while dealing it with the women who are also facing issues of flood and all. So I was trying to understand that how is she going to, arrange these factors and analyze it. So I think the mixed method has given much more justification in bringing the overall argument of the topic you have taken. So the methodological rigor has really justified the topic of the study. And I said that theoretical engagement, as Meenakshi is, good enough for that. I don't need to say anything on it. So next paper on Kennedy's paper, I think Sir was talking mainly about the initiation ceremonies and all on the stage of recognition of puberty. There was a local term in the Assamese culture, but again, I think in every culture, every community, we have such kinds of ceremonies and rituals, no matter how developed or how much of modernity is been actually coming into the different communities in the Indian social structure. Where Sir was mentioning about the socialization process and how the socialization has given a major impact, and also try to understand the overall physical and mental process of health status. This is, I have already appreciated Sir about the way he has taken, the way he has come out to present and discuss the paper. And I think such kinds of the studies, whether it's in terms of Mary Douglas pure and impurity or pure and pollution concept, or say the taboos to touch or not to touch, of all these significances should be discussed by every one of us whenever, wherever it is possible. The last paper which Kalindi has given, definitely this is something which is the need of the hour for us to reflect upon when we talk about marginality, when we talk about different kinds of resource depletion, because there is also always a kind of social construct which is being made by different scholars by not actually knowing what actually is happening or what is being required. She was also mentioning about the focus on intersectionality and how much of the importance on intersectionality has been given in the recent studies, or what is being missed by the earlier thinkers and all. It's something which is very much interesting. The very interesting point which she has brought out is that this is also trying to connect with the sustainable development concept, and also looking at not only the gender dynamics, but considering the health aspects of the woman folk. So this is really, I think, a very detailed account of understanding the rigor, the overall discourses, and general narratives of different forms about gender, health, and development policies, which we need to think through again and again. And more studies are, I think, expected from this field with the changing difficulties and challenges we are having at the moment. So I don't know, I know that means I have taken much more time than the allocated one. I'm so sorry, Kiran. So this much of the comment and appreciation goes to all the presenters. Thank you.
Thank you so much, Dr. Hemlata. And I think I would like to thank all the speakers and all the participants. And thank you, Chair and Co-Chair. So now we will end the session. Again, we'll meet at 2 p.m. Thank you. Bye-bye.
Thank you.